This conference will now be recorded.
Okay, so hi all, and I'm very happy to have you all today here on a Saturday afternoon. And hi Prajakta, Saranjit, Dr. Gopa, Deepa, Saida Sara, Dr. Asma, Dr. Ryan, Sudeep, Sarumurthy, Sadaf, Dr. Javeria, Dr. Anam, Ghazala, Saima, Safa, Prajakta, Karmeen, Kha, Dr. Rehana, Sarumurthy, Kin, Sugra, Reema, Rehana. It's lovely to see you all here today. Anybody has anything? Uh, as from I understand, some of you are giving in January and some are giving in July. We are trying to make CTG concept clear because the questions from CTG in exam are sometimes very challenging. And the reason behind that is uh, some of us in our centers, we don't follow the routine CTG thing, and we some of the setups even doesn't have the machine for CTG, and they don't believe in CTG teaching and things like that. So then it becomes very difficult and challenging for us to understand. First of all, the challenge is to understand CTG, and then the challenge is to apply that knowledge to the questions given in the exam. So most of the time labor module is quite difficult in exam, and we always find it difficult in exam. For everyone it is, and it was for me also, to be fair. It was never easy for me to interpret CTG and apply it because in exam basically it's not so clear. It's very, very bad image, poor quality image. So sometimes it become very, very difficult for us to understand even what is written in the CTG and how to choose. So let us discuss what could be the tricks, how we can read it quickly and apply it in our question quickly and get a right answer. So let's start. Let's start our webinar on CTG today. Hi, Sadaf. Okay, so some of you must be knowing me, and who doesn't know me, I'm Dr. Shweta Santalia. I'm MD from India, and MRCOG I have finished in 2019. I was in Saudi Arabia for 4 years, and now recently, 6 months back, I relocated to London, and I'm working in Bath's Health NHS Trust in London. It's a big setup, very, very busy setup, and every shift of my labor ward, at least we have 10 to 15 deliveries, and we have many instrumental deliveries and things like that. So CTG is an immense part of labor ward monitoring, and that's why when you give MRCOG Part 2 exam or Part 3 sometime, they give you CTG images because being an MRCOG, you have to have a thorough knowledge of CTG because you are on field managing the patient, managing the CTG, taking decision on that basis, and informing your consultant. So it's very, very important that being a registrar here, you know everything about CTG. That's why they expect you to know about CTG in and out. I would take this opportunity to congratulate all our successful students of AIM-MRCOG. So these are all who has made us proud, and I'm very happy to be part of their success in MRCOG. So today's agenda is to understand about CTG. This is how the CTG recording look like, and this is how the monitoring is done. This is the contraction probe, which is attached on the fundus of the uterus to record the contraction, which is recorded here. And this is the fetal heart probe, which is put near the anterior shoulder of the baby to record the fetal heart and get a trace of fetal heart. So this is how CTG is monitored. This is how machine look like, and the printer print the recording of the fetal heart. So CTG is basically a monitoring of fetal heart, and it tells about fetal well-being as well as sometime maternal well-being. So both ways it is important, and it is very important to have CTG in high-risk women. So you don't do CTG for everyone. That's the fact. For low-risk women who deliver in birth center here, who deliver in alongside birth center or far away birth center, they don't have CTG facility. So birth center will not have it because in birth center there is low risk deliveries. But anybody become any high risk, like delay in progress, like they want epidural, any kind of thing, if they want, they have to be shifted to hospital, and then they need the CTG monitoring. So that's why the CTG, the doctors mainly are the one who are interpreting the CTG, and even midwives here are very good with CTG. And every year there is mandatory training program of CTG. So it's quite an importance, and it's quite common here to everybody knowing about CTG. Am I audible? Deepa says that I am not audible. Am I audible to all? Can someone message me? Am I audible in the chat?
You are audible, ma'am.
Okay, thank you, Saru. Deepa, maybe, my dear, you can exit and rejoin. Sometimes because of internet issues, you won't be able to hear me. So that's the reason sometimes. Okay, so as I was telling, this is very, very important to have a thorough knowledge of CTG because it's very common here, as I told you. Even the midwives are very good in reading CTGs here. Okay, so the knowledge. Hi, Saishta, how are you? Hi, Sirisha. So the knowledge what we are sharing today about CTG is some of the bits I have taken from CTG NICE guideline, which is the only source of CTG for us, and some from my practical experiences, and I have taken the images from the hospital. At the time of work, I have clicked the images and put it for interpretation here, which are confusing, which can give you an idea that how in exam it would be difficult for you to read. Sometimes it's very confusing. Sometimes even after understanding everything, some CTGs are funny to understand. So that's the fact. But in exam, they give you the clear-cut CTG where you can make a plan where it's clear-cut pathological or clear-cut normal or suspicious where you have to continue monitoring the baby. So these are the three categories of CTG. We'll go step by step from the basics till reading and applying on the question. So you get clarity about how to apply it in exam. Okay, so first of all, let us understand how we monitor the baby. If we don't do CTG, because this is also a very common question in MRCG part 2, how frequently we monitor the baby in first stage and second stage. Can anybody tell me this? If
First
it's a
stage
low
every
risk
15
baby.
minutes and second stage 5 minutes.
Very good. So in first stage, you monitor the baby every 15 minutes. So this is mainly for the birth center where they will be monitoring. Very good, Anam. So in first stage, you will be monitoring the baby every 15 minutes. And in second stage, you will be monitoring the baby every 5 minutes if you are not doing the continuous CTG. This is a common question. Now, when you monitor the baby, will you monitor it before contraction, at the time of contraction, after contraction? How long you have to monitor the baby when you check for the fetal heart? Can anybody tell me that?
Ma'am,
Immediately
after
after the
contraction.
contractions.
Very
For
good.
1
So
minute, ma'am.
immediately after the contraction, and you have to monitor it for full 1 minute. And there you're trying to understand if there is variation in fetal heart or not. Means sometimes you're understanding that it is 140, sometimes it is 145, sometimes it is 150, and sometimes you might be listening only 120 continuously. So if you're listening 120 continuously and it's not changing, is it a good thing or a bad thing? Hi, Safia. If you're monitoring 120 or on your monitor, the Doppler, not on the CTG, if
It's
you're
a bad
monitoring
thing.
120,
Bad
what
thing
are the
because of loss
possibility?
of variation. Loss of variation.
One possibility is loss of variation of the fetal heart. And what is
Absence
the
of
other possibility?
acceleration.
Pardon?
Maternal pulse could be.
Very
The
good.
baby is sleeping.
Yes, it's possible. See, variability will always be there even if the baby is sleeping. So if you are not finding any variability, like you're constantly listening 120, it is not a good thing. Either the baby is really, really suffering, that's why there is no variability, or you are picking up the maternal pulse. So this is what you have to understand in your practical places when you do the CTG monitoring. If there's no variability, sometime it could be because of either you're picking up the maternal pulse or the baby is really, really suffering from the hypoxia. That's why there is no variability. The most important aspect of CTG is variability. It's not the deceleration which are concerning. It's mainly the variability of CTG which tells you how good the baby is. Because the variability is the last thing to go, and once it is gone, that means you are dealing with a bad baby. You're dealing with a baby who is hypoxic. So in exam, it's very, very important that you look for, when you read the CTG, variability is something which will really tells you about how significant are the deceleration, how bad are the deceleration. Because if you have good variability and acceleration with the deceleration, you don't worry much. Then it becomes suspicious, not pathological. So variability is very important fact which you have to understand in CTG to make the right choice for patient management. So we understood that we are going to monitor the baby differently in first and second stage, because the contraction is a stress for the baby. The stronger the contraction, during contraction, the blood supply to the baby is hampered because the uterus is contracting. So the blood supply doesn't come enough. So the baby is under stress during contraction. That's why you don't like hyperstimulation. You don't like too much contraction. The maximum limit is 5 in 10 minutes. If it is more than 5, we tell it is hyperstimulating or tachycystil, because the baby doesn't get enough time to get the blood supply in between the contraction. Because during contraction, baby has to suffer. Baby doesn't get enough. In between contraction is what the baby's comfortable zone, where the babies get contraction, get the blood supply from the mother at that time. So that's why it become very important that you look for how many contractions are there, which will help you in understanding how good the baby is doing. So there are certain indication of continuous CTG. As I told you, we are going to monitor like this every 15 minutes, every 5 minutes. There are certain indication of continuous CTG. So what are they? If you see nice guideline, intrapartum guideline is quite big, quite huge, 90-page guideline. And when you read it once, nothing goes in our brain. At least 3 reading we have to do for any guideline to be remembered well. What happens? Continuous CTG you have to do, you have to, whenever you're trying to remember, use little bit of your logic, use little bit of your way of remembering things, because you have to use your way of remembering things, otherwise you'll keep forgetting. Because at the time of exam, you have to remember all the 14 module in your brain, not only the intrapartum guideline, right? So it is all the long-term memory. So for long-term memory, you have to have a thorough understanding of the topic, how to remember things without memorizing. It's not only memory game, it's mainly the understanding how good you understood, so that you will be able to remember it well. So if you don't understand and you try to mug it up, at the end you are going to forget, because before exam you cannot revise everything. So it's, you are giving the exam from your understanding knowledge, from your distant memory, not from your short term memory of the last 1 week or 2 week revision. So it's very important that you understand the topic well, and you make your own way of remembering it for a longer time, and apply it in your local clinical practice, so that you will not forget it in day out. If you are applying it, then it becomes like very easy for you in exam. So if you see continuous CTG indication, anytime if either mother is not well, you're worried. If mother has hypertension, either severe hypertension 160 110 one occasion, or 140/90 two occasion. If maternal pulse is high, if temperature is high, either 38 or more, or 37.5 on two occasion, or you're suspecting chorioamnionitis or sepsis. So these are the indication, because you are worried that because mother is not well, baby might also get affected. So you are monitoring. There could be certain other indication like pain is continuous. If pain is continuous, it's not relaxing in between the contraction, then you're worried about abruption, isn't it? So when pain is continuous, it is not a good thing. So you want to monitor the baby. Or if too much contraction also, you want to monitor the baby. Is the baby suffering? Because in between the contraction only, baby get the blood supply. So continuous pain, you want to monitor. Significant meconium. Now the word significant is very important. Thin meconium uh, is not important. Significant meconium means thick meconium, like dark green color or black color. So that's significant meconium, lumpy thing when it comes out. So they say in presence of significant meconium. So these are the words you have to take care. The words they say, which are, you know, which makes things difficult, because significant, if I don't know the word of significant meconium, then in thin meconium also I will say that I'm worried for the baby. But thin meconium is acceptable. Significant meconium is thick meconium, where you have to do the continuous CTG. If there's bleeding, definitely if there is bleeding, you're worried for abruption, you're worried for placenta previa bleeding, so you want to do the continuous CTG. So anytime bleeding, excessive pain, always you're worried for abruption. Meconium significant, you are worried for the baby and you want to monitor the baby continuously. So these are few indication of continuous CTG. How they put up this in exam is they give you a scenario that women come with contraction, you ruptured the membrane, you found it thick meconium, what to do? So you will tick the answer of continuous CTG because it is significant meconium. So that's how they make the question. They are not going to ask you continuous CTG is required in such 4 condition. No, they will give you a scenario and ask you what will be your management. The other 3 indications are regarding progress. If there is delay in first and second stage of labor, if you all remember, this is a very common question of recalls, that what is the most common reason of transfer of mother from the birth center to the hospital? So this is the most common reason, delay in the first and second stage of labor. So if there is delay, definitely you are going to augment them. So for augmentation, you will do rupture of membrane and you will start oxytocin. So whenever there is oxytocin, oxytocin is an extra external contraction you are giving, external pain you are giving. So you have to monitor the baby. So if you are putting the baby on oxytocin stress, you have to monitor the baby continuously by CTG. So whenever there is delay, whenever there is oxytocin use, whenever the contraction is either hypertonus, which is longer than 60 seconds, or more than 5 contractions in 10 minutes, which is known as tachycystal. So both of this situation is a stress for the baby. As I told you, you want to monitor the baby if you're worried that baby is under stress or you are giving the stress by putting on the oxytocin drip. You want to monitor. Either mother is not well, or there is something significant like pain, bleeding, meconium, or you are augmenting the labor by oxytocin, or the contractions are either very strong, lasting longer, or it's more in number where you want to see how the baby is coping up with that contraction. So these are the indication of continuous CTG. Once you understand this, you don't have to memorize it and mug it up. So now you got an idea what are the situation you are going to monitor the baby continuously. So this is how the CTG looks like, right? So this is the paper. Usually the paper run with a speed of 1 centimeter per minute. Usually it is written here what speed the paper is running. What is, I have not put the full CTG. It is a piece of it to understand it. So, and different CTG machine shows it differently. So there are two kind of machine. One runs at 1 centimeter per minute and one runs at 3 centimeter per minute. So 1 centimeter per minute is usually used in every setup, and it looks like this. So 1 centimeter per minute means for interpreting any CTG, you have to understand first that what does this marking mean? What does this boxes mean, right? So if you see this big box, this one big box, let me draw it for you. Yes, so when you see this 120 to 100, so this is, if you see, this is the big box. So this one big box, if you see, this is the 20 beats from 100 to 120. So it is 20 beats. And if you see transversely, if horizontal line you see, this one big box is 1 minute. 1 minute means 60 seconds, right? So this is 60 seconds here and 20 beats here. This is very important parameter, because until unless you understand this, you cannot understand what is acceleration, what is variability, how to calculate it. Safia is not able to see the screen. Are you all able to see the screen?
Yes, very clearly.
Okay, my dear Safia, the same solution. If you can please exit and rejoin, because that's the only solution for this hiccups of internet, you know. So as I was telling, this is 20 beats vertically, and horizontally, this is 60 seconds. So this become 30 seconds and this is 30 seconds, right? Here again, here there is 5 lines, 1, 2, and 2 above. So total it becomes 5 lines here in this box vertically. So because it is 20 beats, every small finer line will become 5 beats, right? So one small box will become 5 beats for you. So this one small box up will be 5 beats. I'll just show you in the next. So why it is important to understand? Because if the full one small box you see, the variability will be 5 beats. If the big box you see, the variability will be 20 beats, right? So if you see here, the variability from here till here. So this is 20 beats and 10 more beats. So this is 30 beats. So this is how you calculate your variability. So you have to understand, very important. So you have to understand this, very important, that how much the beats up and how much the beats down. Uh, my dear, I'm not drawing. I just draw the box to show you that what does this one big box mean, so that you people understand that how to calculate the beat to beat variability, acceleration, how many beats up, how many beats down, how much length. According to that, you will understand the time. Like this is 60 second, this is half, so 30 second, and this one big box, so this is 20 beats, so half will be 10 beats, and every small will be 5 beats. So for the present, you understand that this is how the box significance is, right? Then we'll see every aspect separately. Am I clear about how you're going to read the boxes? Okay, good. So the same way, if you see here in the contraction, whenever you have to count the contraction, you have to count in 10 minutes. So this one big box is 1 minute. So 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So if you see, these markings are made at 10 minutes interval. Because for CTG character, always it is like more than 30 minutes, 30 minutes, less than 30 minutes. So it's very important for you to understand that this is 10 minutes. The numbering between the two numbers, it is 10 minutes. The same way in some CTG machine, they write here the pressure of the contraction like 8, 12, 8, 10, 12, like that. So in between that two line also, it is 10 minutes. So one big box is 1 minute. So 10 big boxes become 10 minutes. So if you see here, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. 10 big boxes is 10 minutes. So this is 10-minute trace. So this is total 20-minute trace, right? So in exam, they sometimes give you 30-minute trace, or even sometimes give you less than 30-minute trace. So that is a hint in itself. Yeah, in this, there is no small box, Saranjeet. I'll show you in the next slide, just a minute. Because to understand it, I gave it like that. Wait. Like here, these are the small boxes. If you see here, this is total is 20 beads. So if you see total is 20, so this is 5, 10, 15, and 20. So this is how the CTG looks like: 5, 10, 15, and 20 beads. This is like the Toco probe. So here sometimes they keep the pressures. Now, so for CTG, timing is very important, isn't it? But when I gave my exam, I was like, if there is no 30-minute trace, how I will interpret and how I will do. So this is a hint. This is a hint that whenever there is less than 30 minutes abnormal trace, then you act upon it if it is pathological. So in a way, if they have given you less than 30-minute trace, means most likely it will be pathological, and you can make your decision on less than 30 minutes decision itself. So keep all your brain cells active and open when you are reading the CTG, so that you can make your answers. Now here, if you see, this is the baseline, right? Baseline is for 10 minutes at least, where the baseline is falling. So if you see this CTG, this is up. This is not an actual CTG. This is just to make you understand. So it's looking more like, mechanical sort of thing. It's not the real one. So this is the baseline. If you see, the CTG is falling here. So this makes the baseline. Then what you go up and down become the variability. And then what go up for 15 seconds and 15 beats, it become acceleration. What goes down for 15 seconds and 15 beats become the deceleration. So these are the aspects you have to look for: the baseline, the variability, acceleration, and deceleration. And you categorize your CTG accordingly. So if you don't understand how many beats and how many seconds, you won't be able to label it correctly. Is it acceleration or a variability? Because variability can be from 5 to 25. So don't think that always the big ones are acceleration. It could be simple big variability. So variability could go from 5 to 25. So if you see here, this is the baseline. So the variability, if you see from here till here, so it's quite big. So that's why you have to understand how to calculate things. So now this is from NICE. What is the normal baseline? 110 to 160. What is the variability normal? 5 to 25. And if there is no deceleration or early deceleration, it's reassuring, no problem. Variable deceleration with no concerning character for less than 90 minutes is normal, reassuring. Now, this is very difficult for me to remember in exam. How I will remember so much? 90 minutes more, less, 50% contraction, 30 minutes less, more. So definitely you can't memorize all the things because you'll keep getting confused in exam. So what's the best way of remembering it? Remember the reassuring, remember the abnormal, and then whatever fall in between, you will label it non-reassuring. Because sometime in exam they ask you to categorize the CTG, what kind of CTG it is. So until unless you remember this, this is a must to remember. How you can remember it? One thing, reassuring and abnormal you will remember. Calculate the non-reassuring according to that. And you write it from your own hand. You'll keep reading. You will think that I'm remembering, but you will not remember. You write it, the thing which are the important chart for MRCOG part 2 specifically. You should write them with your own hand and keep it in your room or your workplace where you always sit, the confusing one, so that you keep seeing it again and again. You keep applying it on patient again and again. And then finally, before exam, it will be like you can even speak that in sleep. So that kind of level of remembrance you need for some things like CTG, like CS cervix, the screening of NHS CSP. Some things are really, really important for exam, and it's always important in exam, and there is always a question from that point. So it's important for you to write it on your own so that you will not forget. So reassuring, anything between 110. Most of you must be agreeing that 120 to 160 is what our comfort zone when you view CTG, but you have to remember that it's from 110. Some babies' heartbeat is not very more, so it's fine. 110 is normal. So NICE says 110 to 160 is normal. NICE says variability of 5 to 25 is normal. No deceleration is fine, even early deceleration is fine. So early deceleration doesn't make it suspicious. Please remember this. Early deceleration is just because of head compression of the baby, and it is not suspicious, not non-reassuring. It's a normal feature. So early deceleration is a normal CTG. Variable deceleration with no concerning character for less than 90 minutes. So how you'll remember it? Don't remember it like less than 90 minutes. Remember it 89 minutes. So in exam, you will not confuse because for 90 minutes and more become non-reassuring feature. So you remember it like 89 minutes, it is fine, right? This is for your remembrance. Whatever written here, but you have to understand your way of remembering it. So 89 minutes of variable deceleration with no concerning feature is fine. Early deceleration is fine. No deceleration is fine. Variability 5 to 25 is fine. And baseline 110 to 160 is fine. This is reassuring. Then what is abnormal? Abnormal is if the baseline is less than 100 or above 180. So if something fall between 110 to 100, it will become non-reassuring, right? So the down the range is 10 beats and the up the range is 180 beats. So it's less than 100 and more than 180. 180 will come here and above 180 will come here. That's why I told you, if you try to remember everything, it's confusing. So remember the abnormal, below 100 or above 180. How you'll remember? Below 100 means 99 and 181. So 99 is abnormal, 181 is abnormal. Then the variability, less than 5 beats for more than 50 minutes. Less than 5 beats is a bad thing. Very, very bad thing, believe me. Less variability, less than 5 beats. It's look like a flat trace. It's very bad for baby. So if less than 5 beats for more than 50 minutes, it's abnormal. Can anybody tell me why this arbitrary limit of 50 minutes here?
The sleep cycle.
Yes. Very good. Because the maximum baby sleeping pattern, they say that cycling of CTG. Here it's very common word, cycling. Cycling of CTG means in between less variability, in between good variability. So that is cycling. Cycling means in between the baby sleeping. So baby sleep cycle. Sleep cycle doesn't exceed more than 50 minutes. That's why this limit. Usually they say 40 minutes baby sleep. So they have maximum kept it 50 minutes. So if less than 5 for more than 50 minutes, and the problem is in exam, they are not going to give you 50 minutes trace. The problem is they give you very short trace, maximum of 30 minutes or even sometimes lesser than that. So be careful how many minutes CTG they have given to you. Accordingly, only they will give you the characters of the CTG so you can make an inference of that. So less than 5 for more than 50 minutes. Again, more than 50 minutes, you'll remember as 51 minutes, 51 minutes or more. So less than 5 minutes for 51 minutes or more than 25 for more than 25 minutes. So it's easy to remember. More than 25, more than 25 minutes. So more than 25 beats variability. If you see here, this variability, if you see, uh, if this is 10 10 beats because this is a bigger box, so 10 10 20 30 20 50, 10 10 10 10 20 30 40. So this is a big variability, right? So more than 25 for more than 25 minutes is abnormal. So even big variabilities are not good. That is also known as saltatory pattern, which is not good. That means something is happening wrong with the baby. Why so much variability? Even less is bad, even more is bad. So this you have to remember well. Less than 5 for 51 minutes or more than 25 for 26 minutes or more is bad. Or sinusoidal pattern, we all know that sinusoidal pattern is always bad. It suggests fetal anemia either due to abruption or Rh negative women or something like that. So sinusoidal is always a bad thing. But again, sinusoidal should be continuous, you know. In CTGs, you might see sometimes 5 minutes, 10 minutes of sinusoidal and then it recovered. So it's all right. So that's something you should keep in mind. If it is sinusoidal, if it is continuously sinusoidal, means baby is losing blood, baby is not getting blood at all. So that is worrisome. But if it happen and then the CTG normalize, then you don't have to act upon that. But just keep an eye on the baby by continuous CTG. So these are the variability issues. Then comes the deceleration. In variable deceleration, we already saw that if 89 minutes, I'm not worried. If there is no concerning features and it is less than 89 minutes or less, I'm not worried. So what is the worrisome variable deceleration? Worrisome variable deceleration is with any concerning, we will discuss about concerning character, what is that in detail. First, I'm giving you what is abnormal normal so that first you understand how to remember it. So variable with any concerning features in over 50% of the contraction. That means in 10 minutes, if 5 contraction and you're getting the variable deceleration with concern in 3 out of that, it is more than 50% of contraction. So more than 50% of contraction for 30 minutes. So you need 30 minutes CTG, right? Or less if any maternal or fetal risk factor. Now here is the catch. You should have at least for 30 minutes, but even less is enough to make it the CTG abnormal if there is any risk factor. So what could be the risk factor? Is my audio not clear?
Significant meconium and vaginal bleeding.
Yeah, very good. Is my audio clear, Sudeep?
Yes, ma'am. It's clear.
My
Absolutely.
dear, whoever is not able to listen to it, it's the internet problem at your end. I'm sorry for that. Please go to a strong internet connection or just exit and rejoin. Or anyways, after the recording is ready, it will be in YouTube. So if some of you miss some of part of it, you can again listen to it in YouTube. So don't worry for that. Whatever you are able to understand, if your internet connection is weak, then I'm sorry, it won't be so good hearing for you. From my end, the internet connection is strong, so I'm not facing any issue, I think. Okay, so variable deceleration with any concerning characters, over 50% of contraction we are worried, right? 30 minutes is enough, but even less is enough. So you have to keep that in mind. If less CTG, less than 30 minutes CTG is given, means something you're dealing with the pathological one. Or late deceleration for 30 minutes. Now, variable deceleration is the most common type of deceleration. This is what you should keep in mind, that whenever you see a CTG, most of the time, more than 88% deceleration are variable deceleration. So most of the time it is variable only, which we label differently. Sometimes we label it late, sometimes we label it early, but variable could be variable. Anytime it can come, and that is the most common deceleration. So variable is significant if it is for 30 minutes with concerning character. Late is significant if it is for 30 minutes. So it's not like you see one late deceleration and you're like, oh, this is a late deceleration, I have to take off a section. No. Late deceleration for 30 minutes. Very important for you to understand this. Late deceleration come with chronic hypoxia. If you get a late deceleration, it will never be with normal variability. So variability also will be decreased if it is late deceleration. Consistently, it will show you late deceleration after every contractions. That means the baby is compromised. Variability will for sure less in the CTG. And then you know that this is late deceleration, baby is suffering, I have to do CTG at least for 30 minutes, not only one. Most of the time what happens, what the practical problem, and most of the people who don't know, who don't practice much of CTG, and sometimes they get confused like that, they see one deceleration after the contraction, they label it late and they act upon it. But actually anything coming after contraction could be a variable deceleration also. So you have to look the full picture. You have to look for if it is getting repeated again and again, if it is persistent for 30 minutes, what is the variability of the women? Is there is any acute problem which you can correct? Can anybody tell me what could be the acute problem which you can correct? Like, if late deceleration, are you going to act immediately or you're going to do something? What could be the reason for late deceleration which will recover later?
Placental insufficiency.
Epidural anesthesia, which will cause hypotension.
Very good. So this is transient problem. Epidural anesthesia you gave, suddenly there will be hypotension. That's why we preload the women. But in spite of preloading, sometimes there will be hypotension for the women. And you might see either bradycardia after epidural, or you might see the deceleration after epidural. But it will improve once you replace the fluid. It is not because of the baby's chronic hypoxia. It is because of the maternal condition. So CTG is not only related to baby, but also to the mother. If mother is having hypotension, the CTG will show problems. Once you correct that, it will disappear. So one example is epidural, where you get funny trace after the epidural and which improves after you replace the fluid, or sometimes a vasopressor like pseudoephedrine, uh, they give here in the hospital by the anesthetist to recover the BP. The other could be, yes, maternal, Safia, if any time you get any abnormal trace, your first action will be to see if the mother is dehydrated. You will give left lateral position, you will give hydration. But I'm talking about late deceleration, which are disappearing, which is due to acute events which is recoverable. And some are the acute events which are not recoverable. Like if there is abruption, If you're getting late deceleration, it will be forever late deceleration. It will not improve at all. But if it is due to epidural, due to hypotension, it will recover. So that's the difference. Usually if late deceleration come, if it is significant, it shouldn't disappear. And it should always present with decreased variability. So that's the importance of understanding that. Why I'm telling all this is because most of the time people label variable deceleration as late deceleration. So you should understand the difference between these two. The third thing is bradycardia. Definitely we all are worried about the bradycardia. If the baby is having bradycardia, nobody is going to wait. So it's a 3-minute rule. 3 minutes of bradycardia, you are going to prepare yourself to act. 6 minutes of bradycardia, you will see if it is not recovering, shift to theater. 3 more minutes of bradycardia, 9 minutes you prepare for section. Or if it is fully dilated, deliver the baby by instrumental delivery. So bradycardia is 3-minute rule. 3 minutes, decide to act. 3 minutes, you're going to act. Shift her to theater. 3 more minutes, act. But if it recovers, sometimes the bradycardia also will recover, right? So the bradycardia could be because of fetal, sometimes the position, sometimes cord compression, sometimes epidural again can lead to bradycardia. So these kind of bradycardia will improve. So even in bradycardia, you will look for acute event that there is no abruption, there is no cord prolapse, things like that where you have to act immediately. Otherwise, you will give her left lateral, give her fluid, give her resuscitation, and you will see if it is improving or not. So whatever kind of CTG abnormality you get, your first job is to make sure hydration is enough, make sure pain relief is enough, make sure left lateral is there, and at the same time, you will keep acting. So if bradycardia persists for more than 6 minutes, it's time for you to act. Or a single prolonged deceleration, the same thing, lasting 3 minutes or more, you're worried. So this is how you'll remember. This I'm telling you how to, this is how I remembered in my exam. And I'm giving you a hint how to remember because I found it really difficult when I try to memorize these all. I never used to remember. So I tried then to remember first category and last category. And whatever will not fit in these two, I will put that in non-reassuring. Okay, so normal, now to categorize CTG, what is normal? All features are reassuring is normal, right? So all features are reassuring means the pulse is, the baby heartbeat is between 110 to 160, variability is 5 to 25, there is either no deceleration or early deceleration or variable with no concern for 89 minutes. What is suspicious? If one non-reassuring, it becomes suspicious. So either the baseline is or the variability or any kind of deceleration, it becomes suspicious. Then what is pathological? Pathological is either two non-reassuring or one abnormal. So once you remember this category, you can categorize it accordingly. So pathological could be two non-reassuring or one abnormal feature. In any CTG trace, either it is suspicious or pathological, you are going to correct the causes. You will look for hypotension, you look for hyperstimulation, because whenever you give oxytocin drip or you give propes or prostin, there could be hyperstimulation. Hyperstimulation means more than 5 contraction either, or more than 60 seconds lasting contraction with the drugs you are giving, with the artificial stimulation you are giving. So hyperstimulation you will look for, you'll stop that or decrease the oxytocin drip or stop it if CTG abnormality like that. You will look for the mother. As I told you, the CTG is a reflection of maternal well-being also. So you look for anything else for the mother, like she's dehydrated, she's in sepsis, there is meconium, thick meconium. These are all things you will look for. You will start the conservative measures straight away. You will inform the obstetrician and you will act. Why it is written obstetrician? Because here it is under midwife care, so they will inform the obstetrician. Now, again, for pathological also the same thing, but the only thing different is you have to exclude the acute event, because if it's just a pathological CTG, sometimes it could be due to cord prolapse, could be due to placental abruption, could be uterine rupture in cases of VBAC. Sudeep, in hyperstimulation, it's not necessarily always that fetal heart will be abnormal. I'll be coming to that slowly. But with hyperstimulation, it could be a normal fetal trace or it could be an abnormal fetal trace. It could be both. So it can present in both way. And in our setup, with the, I don't know what is the problem with the propes. It's always hyperstimulation with the propes. So with hyperstimulation, not necessarily you have to get an abnormal fetal trace. It could be normal, it could be abnormal. If it is abnormal, then you have to give the terbutaline. If it is normal, no need of terbutaline, just remove the propes is what the treatment. So we will discuss that in the coming slides. So in pathological, first of all, the most important aspect is exclude the acute event. There shouldn't be any cord collapse, any abruption, any rupture. So if it is, so why it is important, you have to read the scenario completely, not only read the CTG. If it is a VBAC lady, if it is an IUGR baby, if there is any high risk for cord prolapse, abruption, like she's a hypertensive woman, if there is a high risk for cord prolapse like preterm breach, so these kind of situation. So that's why excluding acute event is very, very important in cases of pathological trace, because if it is acute event, you're not going to do anything but to deliver the patient as soon as possible. If it is fully dilated, always instrumental delivery should be preferred if possible. If not, cesarean, category 1. So that's the importance. That's why excluding the acute event in pathological CTG is very, very important. And then correct any underlying cause, as I told you, hypotension in epidural, hyperstimulation due to oxytocin drip or anything else. So you will correct that. And then you will start the conservative measures. Then you will inform the women what you are dealing with and what is your further plans and things like that. Now, after doing all this, if the trace is not improving, if the trace is still same, you have removed the oxytocin drip, you have given her terbutaline, then also the trace is abnormal. Now what to do? Then I have to act, right? Because this is a pathological CTG. So if I have the fetal scalp sampling facility, I will do that. But if I don't have that, which most of our country doesn't have, then what we are going to do? So we will do the scalp stimulation. So scalp stimulation is something which tells that if you do the vaginal examination and you touch the fetal scalp and touch it, stimulate it, then most of the time if the baby is good, it will improve. The CTG will improve. You will see either acceleration or you will see the variability has improved. So this is a kind of reassurance to you that with stimulation, the baby is doing well. That means the baby is fine. That means you have time, but that doesn't say that you don't have to monitor, you don't have to act upon. That is a kind of reassurance to you, but still you have to act upon it. Okay, so sometimes in exam they give you the pathological trace and they tell you either they will give you a question of acute event which you will deliver, or they will not give you an acute event and they will tell you what is your next step. And there will be a contraindication for scalp sampling. So if you can't do sampling, then what will be your next step? So then your next step will be to offer the fetal scalp stimulation. Digital fetal scalp stimulation is what you're going to do. So this is how they make the question. The possibility, what are the possibility with pathological CTG and what you have to do with that. Am I clear till now? Anybody has any question?
No, ma'am.
Okay, so can anybody tell me what are the contraindication for sampling, scalp sampling?
It is risk of fetal-maternal infection.
And inherited bleeding disorders in the baby.
Yes.
Yes, there are 5 reasons where there are 5 things where you
Preterm.
can't do the sampling. So 2 you already told, 3 more.
Acute conditions.
Very good. So acute conditions means anyways you are not going to wait. So what is the point in doing the fetal blood sampling? No point. It's delaying unnecessarily, right? So acute event you are not going to wait because
HSV
you are going to
infection.
deliver. Pardon? Yes, can you repeat, my
Uterus
dear?
complex
I missed it.
infection in the mother.
Yes, infection in the mother. Sometimes
Okay.
you might have seen in HIV, in HSV, we don't want to transmit the maternal infection to the fetus. So fetal risk of infection transmission to the fetus is a contraindication. Acute event, as you told, is a contraindication. Birth should be expedited. The same thing. Acute event needing the expedite birth then no point in doing the sampling. If fetal contraindication, as you told, the bleeding
But the
disorder in the
delivery is
baby,
imminent.
the delivery is imminent. Very good. If the delivery is imminent, no point in wasting your time in doing sampling because you can deliver the baby. So let's deliver. Then the sepsis and significant meconium. This is important because in these two situations, sepsis and meconium, the CTG is not the real picture of what is happening, and any time it can become bad. So CTG is not very reliable in cases of maternal sepsis and in cases of meconium. So you have to be more alert, and in such situation, maybe you have to keep a low threshold to deliver the baby compared to delaying the delivery by doing the fetal blood sampling. So fetal blood sampling, actually, I'll tell you the truth here in UK, the fetal blood sampling is now disappearing. Now I'm here now 6 months, and I heard that from my colleagues. I asked how frequently you're doing. They told that they have hardly seen 1 or 2 in a year, like that. So nowadays, the practice of fetal scalp sampling, this fetal blood sampling, is decreasing because they think that it is more of a delay, and at the end we get a compromised baby. It's not worth taking the risk because nowadays you all know that cesarean has become so common, simple, and people accept it so easily. So that's the difference of practice which is coming, which will soon reflect in the NICE guideline, is what we are expecting. So that's the thing. But for exam purposes, fetal blood sampling, when to do, when not to do, is very, very important for you to understand. Whenever you need to expedite the delivery, you are not going to waste your time by doing fetal blood sampling. In exam, they always like to ask you about fetal blood sampling, how frequently you're going to repeat. So these are all more of a theoretical thing nowadays because practically it has become less and less here, even in UK. So let's see what you do with the fetal blood sampling. The other urgent intervention we already saw, acute brady and deceleration. So again, you have to rule out the acute event, and you have to expedite the birth if bradycardia persists for 9 minutes. Now, whenever you see a CTG, it is not only CTG reading, it is the full reading of the mother scenario. So it's come under the heading of Dr. C. Brapado. It look very good if you want to remember it in formula. If you are a formula person, it's good to remember it like this. DR is define the risk, C is contraction, DR define risk, C is contraction, BRA is baseline rate, so this is baseline rate, V is variability, A is acceleration, D is deceleration, and O is overall outcome of the scenario. So define risk, why it is important. That's why it's always a scenario, right? The lady could be VBAC. She might be having a IUGR baby. She might be having a hypertension, preeclampsia. She might be having sepsis. There might be thick meconium. So these are the risks which you have to keep in mind, right? These are the common risks we see in our clinical practice. Then you will look for contraction because all your definition of deceleration depends on, is it variable, early, late? So if you don't know where is the contraction, how many contraction, you won't be able to understand what kind of deceleration you are dealing with. So contraction, number of contraction, is it tachysystole, is it hyperstimulation? All that you should understand by understanding the contraction. Then the baseline rate, as I told you, whatever fall in the base for 10 minutes become the baseline rate. Then the variability, what we go up and down, acceleration 15 seconds and 15 beats up, deceleration 15 seconds and 15 beat down, and overall outcome is from all this. Like for a VBAC lady, if I see deceleration, I'm more concerned compared to a primate who is having deceleration, right? Because CTG abnormality could be a sign of uterine rupture. So that's the reason we should look the women overall, not only the CTG. Don't read the CTG, read the women full scenario and then make your decision. Now, we saw that what is the baseline in a normal CTG. If you see, the normal baseline should be 110 to 160, right? If the baseline is more than 160, it becomes suspicious for us. It is a non-reassuring feature. So how the baseline will look? Here there is no number. So if it is more than 160, it will become tachycardia. So this is how the tachycardia will look like. I'm just showing you how it looks like, and then we will apply in our questions that. Now acceleration, how it look like. If you see, this is the baseline. This is a CTG, right? So this is the baseline falling. Above the baseline, 15 beats and 15 seconds. So we know 15 beats means 3 small boxes. So 3 small box up, the 15 beats, and 15 seconds means one horizontal thing is 60 minutes. So 1/4 of the horizontal line will become the 15 seconds. So more than 15 beats, more than 50 seconds will become the acceleration. Usually it look like this. It should start from the baseline and it should end at the baseline. That is very important. The acceleration should start at the baseline and end at the baseline is what you're looking for. So this is how it looks like, starting at the baseline, going up, coming back to the baseline, right? So this is how acceleration look like. How the early deceleration look like. So early deceleration, they say, is a mirror image of contraction. How it is mirror image means the beginning of contraction, the beginning of early deceleration, the peak of contraction, the peak nadir of early deceleration, the end of contraction, the end of the early deceleration. And it will be gradual. It will never be sudden. It will never be like dip and up. That is most likely variable. U-shaped are usually variable deceleration. Sudden drop is always variable deceleration. So it will take little time to dip. It will take little time to recover as the contraction gradually build and gradually die down. The same way the deceleration will gradually come down and gradually up. So it's always gradual and it's always a mirror image of the contractions. So this is how you define early deceleration. If you see the contraction, mirror image means not, it doesn't mean that it should be that deep. It means it start at the same time, peak at the same time, end at the same time. So this is how early deceleration look like. And whenever you are having an early deceleration, the CTG will be perfectly fine. There will be good variability. There will be acceleration as well. So you don't have to worry. By seeing the trace itself, you'll recognize that this is not something concerning. So if you see from here to here, 30 seconds, and then slow recovery, slow down, slow recovery is what early deceleration. Now late deceleration. Late deceleration means it should be after contraction. We all know it is after contraction. So onset, nadir, and recovery will follow after this. So beginning of contraction here and your beginning of deceleration is here. So it is after the contraction starting and then dipping and then recovery. And if you see here, you will see in the images also, in explanation of images also, if you see here, the variability is very less. It's almost nil variability. So late deceleration doesn't come alone if it is significant. If it is not transient and is going to persist, it will always be with less variability. So that's the beauty of late deceleration because it's a sign of hypoxia, chronic hypoxia. So baby is not going to recover. So it will keep coming and it will keep becoming more and more worse. So you will see that the variability will be less. Baby is struggling and at the end baby has give up. So the variability is less. Then the variable deceleration. Now if you see this is U-shaped, sudden drop, sudden up, right? So this is the variable deceleration and this is a typical variable deceleration. The shouldering here, and the deceleration. And usually there will be, because this is just made trace, you will be able to see some variability when it is dipping and upping also, there will be some variability here. So it's a good sign. There is a variability, there is a shouldering before and after. So it's a good sign that it's a good variable deceleration. It's no concerning features, right? So deceleration, sudden drop, sudden up, and it could be with contraction, it could be after contraction, it could be before contraction. So sometimes what happens, if you see it after contraction, you label it late, but it could be variable because variable could be anywhere. So variable word itself is very, very important that it can differ in size, shape, its position. So some deceleration will be small, some will be big, some will be wide. Everybody is able to see the slide of variable deceleration?
Yes, clear.
Okay. So onset to nadir will be less than 30 seconds here. Sudden drop, not the gradual drop like here. Gradually it is coming. As the contraction picking up, gradually it is coming. The variable will be sudden drop because it is due to cord compression, right? So cord will get compressed. So how the baby will get the blood supply? So because of the vagal stimulation, the heartbeat is dropping. So that's the reason. That's why all this uh, shouldering is because the cord is having artery and vein, right? Two artery and vein. So the artery is having a strength and vein doesn't have a strength. So vein can get collapse easily, but artery take little time to collapse. That's why the shouldering come before and after. So if shouldering is there, it's a good sign. If sudden drop, variable in nature means the size, shape, and things are variable. The position is variable with the contraction. Then it is a variable deceleration. And as I told you, more than 88% of the deceleration are variable. So when you see a CTG, keep in your brain that most likely it is variable. And with that outlook, you see your CTG, that what you find. Try to fit it into the variable deceleration criteria. If it doesn't fit at all, then only you label it either early or late. So this is what I'm trying to emphasize because this is most common and this is what we see most of the time, and we label it differently. So that's the importance. Okay, so now can anybody tell me which kind of deceleration is this? Okay, let me, anybody can open the mic and describe the CTG for me because this is a clear picture. So describe me that how much contraction in 10 minutes means, and let us take Dr. C. Bravado criteria and let us explain the CTG like that. Yes, anyone is interested to open their mic and explain it to me?
Yes,
The
ma'am.
reminder
This
is,
is
yeah,
okay, ma'am. The baseline heart rate is 140 beats per minute,
very good. And
and there are three contractions in 10 minutes.
very good. So 3, yes. And
Uh, we can see two decelerations.
yes.
That is early deceleration, ma'am.
Okay. So this is early
And the
deceleration. Why you
and the
think it is?
baseline, yes, yes, ma'am.
Why you think it is early deceleration?
It can be because of the head compression.
No, no. I'm telling by seeing it. Why do you think it's early deceleration?
Because the contraction meets with the deceleration, ma'am. It's the mirror image.
Yes. So because it is gradually coming down, up, and it is exactly looking like the contraction. So it's most likely early.
M shape and it looks like variable.
That is the thing. This is for teaching purpose. So you will, when you see the actual CTG, this is not an actual CTG because in actual CTG, the image doesn't look like this. This is a made up CTG to show you how it looked like.
Okay.
You get my point. When you see the real CTG, you will understand how difficult it is to, interpret things. This is just for training and teaching purposes. So don't take it as an acute drop and acute up. If you see, it is not U shape, but V shape, right? It is V shape, not U. So this is also V shape. This is also V shape. So this is how they're trying to teach you. I'm not telling that it's exactly looking like early deceleration, but if you see this is a gradual drop and gradual up. If it is sudden, maybe this I will say that it is more sudden, but still it is V-shaped, not the U-shaped. Are you agreeing with me?
Yeah.
So here we are trying to understand things, and actual application will come in with the actual CTG. This is only for understanding purpose. So when it will come actually, you will understand that how difficult it is to interpret. Okay, and what about the variability? How much is the variability?
It's more than 5.
It is more than 5 because you can see the trace nicely up and down, but how much you feel is the maximum variability here?
No, 15, ma'am.
bits.
10 to 15.
Yes. So it is, if you see here, this is in the small box. So it is less than 5 beats. If you see, this is fully filling the small box. So this is 5 beats. If you see filling the 2 boxes, so it is 10 beats. This is more than 10 beats. This is also more than 10 beats. This is also more than 10 beats. Again, it is 5 beats. Again, it is 10 beats. So this is how it looks like, right? And if you see, this is the acceleration, more than 5 beats, 10 beats, 15. So 15 beats, more than 15 seconds. So this is one acceleration. If you see again, this is up and down. So this is also more than 10 beats variability. So somewhere between 10 to 15, the variability is falling here, which is perfectly all right. And in between it is even 5, that's fine, because 5 to 25 we are fine. So I'm not going to label it less than 5 variability, because you have to see the range. You don't have to see that here it is looking less than 5, so it become less than 5. No, but after that it is more than 10. So you will label it 5 to 25 beats, which is a reassuring feature. You will label the baseline 140, which is normal. The deceleration is early, and there are acceleration present. So this is a normal CTG, because early deceleration is labeled as a normal CTG. So this is what we have to understand, that early decelerations are normal. Okay, now someone else can open their mic and tell about this CTG.
Baseline 120.
Yes, 120. And then here it became, but at least 10-minute
Variability.
trace we should have to. If you see here, it started with 120, or maybe I will say 120 to 125 somewhere. And then if you see, gradually the baseline is rising. Now it became 125, then it became 135, almost 140. So you're seeing that the baseline is rising,
140.
isn't it?
Yes.
Okay, and then variability.
And variability, 5 minutes, 10 bits.
Yes, very good. So variability here is approximately 10 beats, but as you see further, when your baseline is rising as well as the variability is decreasing, isn't it? Here it becomes just 5. Either it is filling the small box or it is even less than the small box. So here the variability is, here it is looking good, but here it is decreasing. Okay, next.
Contractions, 3 contractions. They have
10.
given 7 minutes trace.
Yeah, not 7 minutes, I think 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 11, 12, 13, 14, 15-minute trace they have given to you. But if you, the numbers, they have not put in 10 minutes interval. Actually, the numbers are usually at 10 minutes interval. They have put that because it is cut in between. As I told you, this is for teaching purpose, the images. So it's not proper. Usually the numbers are at the difference of 10 minutes. So 10 box is 10 minutes. So here it is 1, 2, 3, 4, 5, 6, 7, 7 box. But this number is erratic. Okay. Then
And the deceleration, because it is starting after the end of the contraction.
yes, so deceleration is looking at, it is consistently at the same ways, looking same. It's coming after each contraction. So it's consistently after the contraction. So you can label it as late deceleration. And if you see, as I told you, the variability start becoming poor, and gradually if we'll continue the trace, it will become further bad and bad and bad. So in a way, they are showing you a correct picture how the how the late deceleration should be. looking like in exam. Okay, thank you, my dear. Can you please close your mic? Okay, now this one. Who wants to open their mic and tell about this? Yes, anyone?
Hello,
Yes.
may I?
Yeah, sure.
There is 1, 2, 3, almost 4 contractions in 10 minutes.
Yes, very good.
Okay. And along with that, the baseline is starting from 130 and it's going up to like between 130 and 135. 130
Yes, and
and
here even
140.
it,
It is
yeah,
140.
so that's
130
fine.
and
Anything falling between that range is fine. Up till
yeah.
15 beats difference in baseline, here we don't consider it significantly. But if it is more than 15 beat change in the baseline, even we take it very seriously. So rising baseline is also bad. So anything
Okay.
between 15 beats difference is fine. So here it is starting at 130, going up till 140 is fine, perfectly acceptable.
And there
Then,
is a variability is normal because it is
yeah,
between the 5
moving
and
like up and down. Yes,
25. And
very
but
good.
there is a D cells that seems like a V shape, and this seems like variable D cells. And there is
Yeah.
no shoulder. Initially there was shouldering sign
Yes, there is
here.
shouldering or there is no shouldering.
In the first, there is seems like a shouldering sign.
Yeah,
Here,
this is
this one.
shouldering, right?
Okay.
Here, if you take it as shouldering, you cannot take it as shouldering because shouldering and then it should come down like shouldering and then it should come down, not like this. So this is not shouldering, it's raised in the baseline. Here, if you
Okay.
see, there is no shouldering here, no shouldering here, and
Here
even
it
it is
was.
looking like W shape. Here also
Ac-
no shouldering, right?
Yeah.
So
It's
V shape
getting
and
worse.
U shape. Basically, V shape and U shape is not a criteria for deceleration. It is just like they look like it. So don't
Yeah.
confuse with it. If
But
it
at
is
the
U
time,
shape, I'll label it variable and V shape, I'll label it early like that.
yeah.
Why you are
But
labeling
let's
it
show the
variable?
time it take to recover.
Pardon?
Uh, the U shape is showing that time it take to recover.
Yes.
And also
So
this variable diesel is going down up to from 130 to like 80. So it is 50 beats is going down. So if it is more than 60, then or up to 60, it will be like labeled as abnormal.
yes, more than 60 beats either or more than 60 seconds. Both way it
Yeah.
is more concerning. So that is a concerning feature of variable deceleration. Now,
Okay.
I want to ask you, I think it is early deceleration because see, this is also with contraction. This is also
It is
with
not
contraction.
mirroring, like, not mirroring the uterine contraction.
But to me, it looks like mirror. See, this is the contraction. This
Sudden
is,
onset and the acute peaks are there in variable.
pardon, acute peaks. Yes, I understood that. But still, I feel that it is corresponding with contraction and looking like mirror image to me.
No, but
So how
sometimes
I
it is
can,
coming before contraction and sometimes it is coming after contraction. Like initial one is started before the contraction.
yeah, very good.
And
And
the last one is after the contraction. Like it started before contraction and recovering after contraction.
yes, so that
So
is
that is,
one thing. That is
yeah.
one thing that it's not very exactly not looking like the picture of contraction, not looking like mirror image, but I'm trying to confuse you because in exam, we do get confused under stress, right? We don't see the finer details. So still
Hmm.
I am thinking that it is coming with contraction. I am not noticing this finer detail that it is starting before and it is ending after. I think it
Hmm.
is early. So how you will further justify it that this is not early but variable?
Um,
I think it is coming with
like
contraction.
number
I
of
think it is mirror
contractions
image.
are more. Number of contractions are more in 10 minutes. Like 1, 2, 3, 4.
Which is perfectly
And
normal because anything less than 5, I'm happy.
Yeah, and lasted for 60 seconds. Okay. So I don't know.
Any other justification?
Um, we have to go for the history of patient.
No,
Like
no.
we have
We are not talking
examined
about
the
history
patient.
here. We are not coming with the
Shouldering,
conclusion of
ma'am.
the outcome. We are only reading the CTG, and I'm trying to categorize it. And I feel that it is coming with contractions. And I am not noticing the detail that it is ending and starting before. Shouldering,
But
I'm
at
not
the end, it is
noticing.
not along with the contraction. The
Yeah,
end contraction.
I know,
No.
but I'm under exam stress, and I'm thinking that it is almost similar with the, look like it's coming with contraction and ending with contraction. So what else?
Because there are
Time.
concerning features, ma'am.
No, I'm not talking about concerning features. Yes, there are concerning features here, but in early deceleration, anyways, there will be no shouldering.
Okay.
The
So
shape is
The
I'm
drop
thinking
is
it is early.
sudden drop.
Yeah, you're right. Sudden drop, you're right. It's starting sometime before contraction, ending after contraction, right? What I'm trying to inculcate in your brain is it's looking variable, isn't it? Is it looking similar?
Shape.
It's
No,
not.
shape is different enough.
It's looking variable. So sometimes when you get stuck like this, where you sometimes not able to differentiate, you will see that variable always look variable. Like if you see this is deep, this is shallow, this is
Yeah.
wide, this is all shapes are different. All size
Yeah.
are different. All
Exactly.
shape and size are different. All four deceleration are not looking same to me. While if you see here, they are looking exactly same.
Yeah.
If you see here, it is almost same.
Yeah.
So that's the difference between the variable from other. It look different. All will look different.
Yes.
It could look similar, but it could look different. So
Okay.
sometimes what happened, I'll give this example, but don't apply it always on your question.
Mm-hmm.
Sometimes there is cord around neck, right, for the baby. So you will
Okay.
see the variable deceleration always with contraction because the cord around neck, and when the contraction come, the cord will get compressed because baby pushing down, right? So there
Yeah.
are many situations in my own clinical practice. When I did my also course, even I asked the teacher that this is what I felt, that sometimes we label it as early deceleration and the baby come out bad because we don't act upon early deceleration and the baby come out bad. What could be the reason? She told me that you are labeling and categorizing the CTG wrong. If it is early, there will be no problem to the baby. Then I thought retrospectively that yes, maybe I'm confusing some other deceleration with early deceleration. Then I went back again in my clinical practice, applied that knowledge, and then I realized then when there is cord around neck, the variable deceleration come always with contraction, and we are labeling it as early deceleration, but actually it is not. You get my point? Variable deceleration is due to cord compression. It should be variable in nature. It should have all these feature or this feature might be absent and make it concerning character. But
So
sometimes
again,
variable deceleration can come with contraction always, but it will become more and more deeper because at the end it is abnormal. So after 90 minutes you are worried according to the NICE CTG guideline. If the variable deceleration without concerning character also, if it is more than 90 minutes, it becomes suspicious. So
sorry to interrupt you, ma'am. As
no,
you
no, no
told
problem.
before that if there is cord compression, there is a shouldering sign, like veins are compressing before then artery, so
Yes,
that is showing. So in case of early decel, it is because of the compression of the head.
yes,
So this point is also make the difference. Like you said
yes.
that sometimes.
That's why there will be no shouldering in early deceleration. But the thing is, variable deceleration with concerning feature also there will be no shouldering.
Yeah, but in cord around the neck, the same scenario will happen. This shouldering sign along with the early
Yes,
decels.
but till 90 minutes you will take it as normal. But after 90 minutes you'll take it as suspicious, right?
Okay.
Even if it
Okay.
is with shouldering. Till
Mhm.
89 minutes, it's normal. But after 89 minutes, it becomes suspicious. So you'll keep an eye and you'll act upon it. If the CTG is continuously suspicious, You'll be worried. You will not leave it as if it is normal.
Okay.
Right. So it raises an alarm in your mind that if, and the deceleration will get deeper and deeper and deeper, because at the end, because of the cord around the neck, the baby is getting compromised. So I'm telling you, in your clinical practice, be very careful to label something as early deceleration, which is changing in pattern. Early deceleration shouldn't change in pattern, first of all. It should be
Okay.
similar. It shouldn't become deeper and deeper and deeper. So if it is becoming deeper and deeper and deep, because usually the nurses, usually the not the midwife here, the nurses outside UK, they're not that much trained in CTG because not much training available to them. So their simple formula is, if it is coming with contraction, it is early. Simple. If I'll show this to a nurse in outside UK where the CTG training is not much, they'll simply say me, this is coming with contraction, it is early.
Yeah.
So we are the one who knows the difference. Then only we can pick out the difference, because we know that it's possible that sometime variable will come even with contractions, and then it will become deeper and deeper and deeper. It will lose the, it will become more concerning features. But for a midwife, if she doesn't know that, she'll keep labeling it as early, because
Okay.
she doesn't understand the difference. She understand only with contraction. If any contraction after any deceleration after contraction, immediately my midwife, not here in UK, outside, they immediately call me, we are having late deceleration.
Mm.
And then I ask, okay, how is the variability, how is the acceleration? They'll say it is good, good variability, good acceleration. Then I understand that it is not late, it is variable.
Okay.
You get my point, what I'm trying to
Yeah.
make you understand.
Yeah.
So
I'm very.
that's the way you have to understand that not all deceleration coming after contraction are late, not all coming with contractions are early. So that feature should be clear in your mind. Then only you can read the CTG in a right way. And as I told you, more than 88% are variable. So try to fit every deceleration in variable deceleration category. And if it doesn't fit into that, then only it is something else. Clear?
Okay, ma'am. Thank.
Okay. So this is variable deceleration, very good, because it looked different size, shape, and as you people told, because you are so expert, you know that it's early dip, quick dip. So all these are supporting the variable. And the good variability itself tells me, and the acceleration tells me that baby is doing good. Okay, now what are the concerning character of variable? Very, very important. Concerning characteristics, the NICE says is lasting more than 60 seconds. So now we know one big box is 60 seconds. So this is almost, the problem is it will not always fill in the box. Now here, it's starting little bit after, but the same space is covered here. So this is almost 60 seconds for me. So you should have that eye to see for it. Lasting more than 60 seconds. Reduced variability in the deceleration means there is variability here, right? If it is a smooth trace, complete flat trace, then it becomes concerning. If there is failure to return to baseline, like here the baseline started at 130 and when it returned, it went up to 135. So it's concerning, right? Failure to return to the baseline. Biphasic. So this one you can take it as biphasic, W shape it. You'll not exactly see the shape like we write our alphabet, obviously. Like if you see this also look to me like W shape it. So it's just a way of telling you that it doesn't look smooth. It look with the, cut. And no shouldering, of course. Here it is no shouldering. Here it is no shouldering. So these are the concerning character. If you don't understand that, you cannot apply here and you will not be able to label the CTG abnormal, pathological. Because with concerning character, can anybody tell me what is pathological with concerning character? How much time, how many contraction?
More than 50%
More than 50% of
over 30 minutes.
More than 30 minutes or 30 minutes?
30 minutes or less if there is any maternal or fetal concern.
Yes. So this is very important. 30 minutes or even less. And more than 50% of contraction, right? So that's important. So here it is more than 50% of contraction or not?
More than 50%.
Yes, ma'am, more than 50.
Because here
There are
7 contractions, here 1, 2, 3, 4 decelerations. So it is more than 50%.
And even I can take this one also as a deceleration, if you see, right? So if I take the baseline like here, the same, it could also be. So anyways, 4 or 5 variable deceleration and 7 contraction in total. So it is more than 50% of the contraction, right? And if they would have given me 30-minute trace, I can make a decision for this. Or if they give me an IUGR baby or something concerning, even this is significant for me. So this is how they make the scenario. So in exam, open your eyes, ears, everything, and try to read the scenario and at the same time interpret the CTG correctly. Then you'll definitely get a right answer. And the concerning characters. So this is how the concerning character, again, to emphasize more, this is a pure variable. There is a shouldering, there is a variability. This is no shouldering at all. This is prolonged more than 60 seconds, and even whenever there is a prolonged variable deceleration, you will see an overshoot sort of pattern, means it take a longer time to recover, like this slow recovery. So this is further bad. This is also slow recovery and overshooting. This is called as overshooting because baby is struggling, there's no shouldering, then it dipped, and then baby is taking further time to come back and then cannot come back to the baseline. It is going towards tachycardia. So this is called overshoot, and this is also called overshoot. This is the start of overshoot. This is quite a significant overshoot sort of thing because it's taking long time to come back, and then it is overshooting the baseline. So this is called overshoot, which is bad. And this is the clear-cut W-shaped biphasic deceleration, which is bad. So these are the things which you're worried about. If you see that in variable deceleration, it becomes concerning characteristics. And then for 30 minutes itself is fair enough for you to act. And more than 50% contraction is fair enough for you to act. Okay, so this is just a summary. Just go through it and give me a break of 1 minute. I'll be back. Okay, so I'm back. So as we all understand, this is a normal accelerative trace. This is just for teaching purpose, so don't try to analyze it too much. Anything above the baseline, good, wide, you think it is acceleration, good. Healthy trace. Early deceleration is due to head compression, so that's why it doesn't deteriorate or things like that. It maintains at the same level. Can anybody tell me when early deceleration come? What stage of labor?
Second stage of labor.
Second stage.
Will it always be with second stage?
When we do PV also it can happen, ma'am.
Usually when you do PV, you stimulate the fetal head. Usually there will be acceleration rather than deceleration. It is a head compression, right? So late first stage, very good, Rehana. So late first stage also you can get early deceleration. But in early first stage, you will not get. So also keep your brain open that somebody is 4-5 centimeter, you are not going to get early deceleration. So most likely it is variable if it is at 4-5 centimeter. But if it is at 7-8-9 centimeter thin cervix, then it could be head compression. And then we apply our knowledge of how it looks like and things like that. So either late first stage or second stage, you see the early deceleration, and maximum 5%. The incidence, if you see of early deceleration, it is only 5%. And if you see, when I was working, no offense to anybody, it's even my knowledge was not that strong when I started reading CTG, but most of the time in our hospital setup, when I was not in UK, we used to label the deceleration as early deceleration. But actually it is only 5%. So we are misinterpreting the CTG. We are labeling variable deceleration as early, and then at the end, the outcome can be affected. So it's not very common. Keep it in mind. It's not very common. Don't try to label early any deceleration as early unless it really fit into the criteria, because it's only 5%. Variable deceleration, 88% or more. So it is the most common one. And if you see, even in picture, the different shapes and size and things. Late, as I told you, with decreased variability, and it will be consistent, similar looking, always like that. So it's uteroplacental insufficiency, and always you have to correspond it with the contraction. But don't get carried away that after always remember that variable could be with contraction, variable could be after contraction, variable could be before contraction. So variable is a variable thing. So that's the tricky situation in cases of CTG. Okay, good. Anybody has any doubt? Anybody has any doubt till now in how you are going to remember the nice CTG criteria, how you label it, how you read the CTG, and how you'll fit it in criteria, how you look for acute events, and how you'll act upon that? Okay, that's good. Now, this is the sinusoidal pattern. Okay, my dear, thank you. So this is the sinusoidal pattern, which is like they say that it is a sine wave pattern. Okay, so sine wave pattern means it's like undulating, like it's like look like sine wave, like we draw the the wave, how we draw. So this is what sinusoidal pattern is. The most important thing is the amplitude will be 5 to 15 beats. So if we take half box as 5, half box 10, so this is 10 to 20, right? So this is just for teaching purposes, as I told you. If you see in real CTG, it will look like this. So this is 120 beat, this is 140 beats. Now, the other problem is in exam, it is not very clear like this. That's why I have not given you very clear pictures. So you know that 20 bit difference is there. So this is 120, this is 140. You can't read 140, but you can read 120. So you understood. And if you even can't read this, you go from your this thing like 60, it start from 60. So 60, 80, 100, and then this is 120, and this is 140. So between 120 and 140, if you see, it is almost half of the boxes. So 20 beats is the total difference. This is approximately 10 beats. So it's 10 beats, somewhere between 5 to 15 beats it should be, and it should be 2 to 5 cycle per minute. So if you see, this is 1 minute, right? In 1 minute, if you see, you are seeing 1.5. In 1 minute, 1. In 1 minute, 1.5, like that. So it could be 2 to 5 per minute. Anything could happen. And it will be fixed. It will be fixed means the pattern doesn't change. If you see, it's same height and same breadth sort of thing. So it's not changing. So it's not a variability. It's a sine wave pattern. So this is how the sinusoidal trace look like. That's the importance. Then it should be at least for 10 minutes, and it shouldn't recover. If it recovers, supposedly it is for 10 minutes and then it disappear and become better, then I'm not going to label it as sinusoidal pattern. So if we already started, are you able to listen? Hello, are you all able to hear me now?
Yes, ma'am.
Okay, so as I was talking about sinusoidal pattern at least 5 to 15 beats amplitude and at least 2 to 5 cycle per 1 minute, and it will be same way. It should last at least 10 minutes, then you will tell it is sinusoidal. And then if it recovers, you're fine. Sometimes the baby can get sudden hypoxia and then it recovers. So if it is persistently like that, then you're worried that it might be abruption, it might be RH incompatibility leading to something, and then you will act upon it. So that's the main concern for sinusoidal. It should be persistent, it should have a proper pattern, then only you will label it as sinusoidal. And this is not variability. This is sine wave pattern, which is very detrimental for the baby. Okay, now the main thing is we always get confused about what is tachysystole, what is hyperstimulation, what is hypertonia, what to do in such situation. So how much contraction is enough or how much contraction you want? At least 3 is what literature says, that at least 3 should be there to do the regular cervical dilatation. But your aim is up till 5. Anything less than 5 is fine. 5 or less is fine. More than 5 is what make you worried. Because as I told you, in between contraction, baby get the blood. So more than 5 contraction per 10 minutes. Naturally, if it is happening, it becomes tachysystole. And the same thing if it happens with stimulation, either with oxytocin or prostaglandin, the term become hyperstimulation because you have done it now. You have stimulated the uterus, so it become hyperstimulation. So if it happens naturally, it is tachysystole. If it happens with you doing something, it become hyperstimulation. Hypertonia means the tone is lasting longer. So if it is more than 60 seconds lasting contraction, it become hypertonia. And then you're worried because so long the baby is not getting blood supply. 1 minute baby is not getting blood supply. You're worried. So hypertonia and tachysystole, any of these with oxytocin or prostaglandin become hyperstimulation. In hyperstimulation, the baby heartbeat could be normal, could be a normal accelerative trace, or could be abnormal. So what they ask you in exam is, they give you a scenario of hyperstimulation with oxytocin 60 ml per hour going on, and she's having hyperstimulation, and the fetal heartbeat is normal, accelerative trace, or whatsoever, the variability is normal, no concerning feature. So what you will do? So because she's hyperstimulating, you're worried that at some point baby will become bad. So you don't want the hyperstimulation to continue. So either you will decrease the oxytocin drip or you will stop the oxytocin drip. But you will not give her tocolysis. because tocolysis is bad. You want to deliver her. You don't want her to again relax uterus and then again stimulate her from the beginning. Anybody in labor giving tocolysis is bad. So until unless it is really necessary, you will not give tocolysis, right? So if the fetal heart rates become bad because of hyperstimulation, then you have to choose the answer of stop oxytocin or remove propes and give terbutaline. But if the trace is normal, then you have to choose the answer of stop oxytocin or remove propes. So that's the difference. That's they always put the EMQ. EMQs are always like 2-3 scenario, right? To understand your in-depth knowledge of in different situation what you're going to do. In tachysystole, what you can do then? For hyperstimulation, at least you know that you will stop the stimulation thing, you will take that out, you will stop oxy, and if the CTG is bad, you will give tocolysis. But for tachysystole, if they give you in scenario tachysystole, what you're going to do? Because it's happening naturally, you have not done anything. So usually in exam, the answer is painkiller, pain relief. Tachysystole, they will give you, she's feeling 5, 6, 7 contractions per 10 minutes painful. So what they expect you is to give her pain relief because you have not done anything. So how can you stop it also? But yes, again, if the CTG trace is bad, again, the role of tocolysis comes. So tocolysis only when the CTG is abnormal, otherwise no need of tocolysis. Only control her pain, and if you are giving stimulation, decrease your stimulation is what they want you to choose in the options. Am I clear about this fact? Okay, great. Now, if there is pathological CTG, what you are going to do? First of all, you have to do the conservative measures because any pathological CTG can improve by giving hydration, by giving left lateral. So do that and rule out the acute event is very important. We already saw. Then if you have the fetal scalp blood sampling facility, you will do that. But if you don't have, you can even do scalp stimulation. So this could be the answer sometime in exam, or blood sampling could be an answer, or sometime expedite the birth could be the answer, right? Because if acute events are there, you are not going to do anything but to expedite the birth. So that's the thing. We already discussed 5 situations where you are not going to do the sampling despite pathological CTG because they need delivery. They are high risk. How to interpret the fetal blood sampling? Either they will give you pH or they will give you lactate level. So in exam, if they give you pH, you have to look for, again, how to remember the upper limit, lower limit, and the middle unit automatically come. So less than equal to 7.2 bad, more than equal to 7.25 normal, anything in between borderline. The same way lactate, high lactate is bad, so more than equal to 4.9 bad, less than equal to 4.1 all right, anything in between borderline. What you will do, fetal blood sampling, if you do a fetal blood sampling and you get a normal result, what you're going to do? You're worried the CTG was pathological, so you did the sampling and the sampling came out normal pH. What you're going to do?
Fetal scalp stimulation.
No, scalp stimulation is not for this purpose
We
basically.
will
Once
see
you're
the
doing sampling means
CTG. If it is recovered, we will continue. If it is not recovered, we can repeat the fetal blood sampling in 1 hour.
1 hour. Very good. So if the trace is still pathological and I did the sampling, it was normal, still I'm worried, I'm sitting tight. So if the trace is still pathological, I'll repeat it in 1 hour time. But if the trace improve, nothing to be done, right? Now, scalp stimulation is the only role of scalp stimulation is where you don't have the sampling facility. Or if in the answers you don't have the sampling option, then scalp stimulation could be your choice. As I told you, all three are the possibilities, but this is mainly when you don't have this facility. So keep that in mind. Once you have done the sampling, there is no role of this. That means you have the facility of sampling. So you will do according to the guideline. So if it is normal, you will repeat in 1 hour if the pathological CTG remains. If it improves, nothing else to be done. If it is borderline, what I will do? You will repeat it in 30 minutes because you're more worried. If it is normal, you're less worried. So you repeat it in 1 hour. If you're worried, it is borderline, you will repeat in 30 minutes. And if it is abnormal, anyways, you are not going to wait and you will deliver. So this is how you have to interpret your fetal blood sampling values. And this is a very common questions in exam of fetal blood sampling values and things. So you should remember it really, really well. And anytime if you need third fetal blood sampling, means you have delayed the delivery already by 1 hour. Like here, I have taken 2 30 minutes apart and still it's abnormal pathological CTG. Third sample I require, then I have to inform my consultant because then something wrong is going on and we might get a bad baby. So then the third sampling, they say that you should inform the consultant. Okay, so whenever you get any abnormal CTG, how to remember what all to do, the conservative measures. So you can remember it by spoiled mnemonic, if you are a fan of mnemonic. Otherwise, it's simple thing. Stop the stimulation, change her to left lateral position, give her oxygen only before anesthesia. So oxygen has no role in fetal resuscitation, maternal oxygen. So don't give that. It doesn't make any difference. IV fluid bolus if she's hypotensive. Low BP, you might consider even vasopressors and tocolysis if the CTG trace is abnormal, right? So stop what you are giving for stimulation. Let the baby relax. Give the baby some time to recover, and then you can restart if needed. So stop oxy and tocolysis if needed, and this all we already know. Change position, give fluid. If BP is low, give the vasopressor. So this is what the conservative measures means in cases of pathological or suspicious CTGs. Okay, so this is all about the understanding of CTG. Now we'll apply that to the questions and I will see how much you got. Now I'll show you the real CTG pictures, which I have taken in my hospital setting. It is not from the, for teaching purposes where you can't, it's the real scenarios. So it's not made up. It's a real scenario where you will be able to test your knowledge, what all you understood. So before jumping into the questions, just wanted to tell you about our part 2 course starting from tomorrow. Exam is on 5th of July, so it's the right time to start. You have 6 months, more than 6 months to prepare. So right start matter the most because you should have enough time to do 3 revisions at least. This is what our student used to say, I'm disheartened, I didn't join earlier. I could have joined earlier and I would have got benefited. So if you think you need help, don't delay it. Start early because the earlier you get right guidance, the more chances of you succeeding in exam. Nobody can make it 100%. It is only you who can make it 100%. And the luck also favors or unfavors sometimes. But you should be prepared for adversity. For that, at least if you prepare with right guidance, it is easy. Because all of us are doing it with our work, our family, many commitment. So yes, right guidance really make a difference at right time. You can do self-study, you can do group study, you can take a course can give you make your path easier because everything you get prepared. Somebody else is working for you, basically somebody else is making notes for you, so it become very easy for you to follow the path. And the group of students who are taking the course can hold each other hand and do the group study, so you move in the right path. Basically you get the motivation from the mentor, so in a way the path become easier because as I told you, we all are doing many things in one time. So you must have seen this earlier, the slide earlier also. You get the schedule, you get the notes, you get the material, you don't have to look here and there. You get the benefit of group study, you get the revision. You can revise the recording again and again and again. It is there with you till exam. So you can revise any module very easily in 3 to 4 hours. So that's a difference. You get the balance of reading and question solving because both makes a difference. And at the end, the mocks. The mocks gives you the real picture, exam scenario, how you're going to perform in exam. So it's very important. These are the benefits if you take a course. It makes your path easier, as I told you. This is how you get the schedule, what to read, what day. So it's a motivation that the other person is reading, I should also read. So if you're lagging behind, you want to cover up. If you're doing alone, okay, today I didn't read, I'll read tomorrow. So like that, you keep getting lagged. So this is our course starting from tomorrow. The early bird is 349, but on students' request, one more day I have extended the 40% discount. So if anybody is interested, can join it for £300 for next 24 hours. This is the course feature. As I already told you, you get the EMQ sessions where you get to understand how to apply your knowledge to the EMQ solving, because the words are very confusing. The question reading is an art which you should master when you're giving part 2. The talks are very challenging because it's too many talks. How to cover so many on your own? So we cover almost 125 talks in sessions, so which really makes your life much, much easier from talk point of view. Flashcard at the end makes a lot of difference because you get it at a glance. EMQ discussion talk sessions are basically really very helpful, is what students told me earlier, the successful students. These are our EMQ sessions feedback, our talk session feedbacks, which really, boosting our morale to do more for the students. So perfect balance is very important. If you only listen to the recording, it doesn't help. You have to do the question solving, because at the end, the exam is all about answering the question in EMQ and SBA forms. So join us and together we can make the difference, as your success is our goal. So this is all about the course starting tomorrow. So let's practice the questions. You all should now this is how a real CTG look like. Okay, so if you see, here is the date, there is a time. Again, it is a cut piece, so you might miss some information. Otherwise, it's also have up and down. And here is the Toco probe, and here is the contraction recorded. And if you see the speed, it is 1 centimeter per minute. This is the heartbeat. Now you tell me, who wants to read the CTG and tell me what you are gathering from this? Yeah, anyone can open and just tell me. This is not a question scenario. I'm just checking how much you understood about a CTG. What is the baseline, variability, acceleration, deceleration? Yes, go ahead. Who has opened the mic?
Ma'am, here the baseline.
Yeah.
Ma'am, here the baseline fetal heart rate is around some 130, ma'am.
Mm-hmm.
And the beat to beat variability is around some 10 beats per minute, 5 to 10, 15 beats per minute.
Mm-hmm.
And there are three accelerations. There are accelerations.
Mm-hmm. So
So it's
how
a
you will,
normal CTG trace. All the features here are reassuring. So it's a normal CTG trace.
very good. You told me the baseline is 130.
Yes, ma'am.
Are all of you convinced with that?
No, no, it is 140.
Yeah, 140.
Actually,
135.
here it is 140 if you see, and then gradually dip to 135 because 130 will be
35.
here. So
Hmm.
130 is not fitting well, but yes, 135 to 140 is the
135.
baseline. Here again it became 140.
Okay.
So if you see, the baseline here is 135. So 135 to 140. It doesn't make a difference when it is
Okay.
falling in between 110 to 160, but I'm trying to making you more precise so that in exam you'll be able to understand if it is 160 or more or less or whatsoever. So very
Okay.
good. The CTG is normal. If you see, the baseline is good, variability is good, accelerations are there, no decelerations, so it's a perfectly all right CTG. The contractions are very less, 1 If you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 2 contraction in 10 minutes, very mild, right? So this is the CTG, which is a normal looking CTG. Okay, now this one. Whoever is not speaking, please close your mic so that the recording will be better. Whoever is speaking, only open your mic. Yes, who wants to describe this?
I can try.
Yeah, go ahead. Who is this?
This is Maya.
Because many mics are open, so I don't know who is speaking. Okay, Maya, tell me.
Difficult to comment anything about the baseline, but what I can see is, just give me a moment.
Sure, sure. Go ahead.
Yeah, so it is difficult to really comment about the baseline. Probably the baseline must be around 160.
Mm-hmm.
There is a very less time for the baby to go back for the recovery, so the recovery time is really reduced.
Mm-hmm.
There is a lots of decelerations. They are
Mm-hmm.
variable,
Mm-hmm.
and there is no loss of. I mean, the variability is also lost at the time of decelerations,
Mm-hmm.
so that's also not a very good sign.
Mm-hmm.
Um, this looks like a subacute type of hypoxia.
So what is the CTG? Is it normal, suspicious, or pathological?
This is pathological. This looks like pathological.
Very good. So this is what you have to do in exam. You should be able to label it in some way. So here, what
Hmm.
are your non-reassuring features?
So there is a baseline variability is definitely reduced. It is less than
Mm-hmm.
5. We cannot make out anything about the baseline where exactly it is. We can only suspect that it could be because there is no recovery time for the baby. So the baby is most of the time decelerating, but it is not coming back to normal.
Very good. Hmm.
And
So one thing you told me, decrease in variability, is what your non-reassuring feature. What is the other non-reassuring feature?
presence of decelerations, which are quite significant, variable.
With
Uh,
variable deceleration with
with decelerations also. So it's almost like
With
flat
concerning
line. That,
features.
yeah, that
variable
is there. That is a
deceleration
concern.
with concerning feature, right?
With concerning features, yeah.
Because there is no
There
variability
is
as
no
well as
shouldering.
some are
There is no
W shaped.
shouldering. Yeah,
Now, if you see, this is what the eye you need. This is W shaped. This is W
yeah,
shaped, right?
yeah,
This is W shaped. There's no variability, no shouldering. So many concerning feature of variable
yeah,
deceleration. You're perfectly all
yeah.
right that the baseline difficult to comment upon. But if you ask me, I
Hmm.
might take 180 as the baseline. You see, only here
Mm-hmm.
it is sustaining for a while. Here it is sustaining for a while. Otherwise, it is all like dipping up and down. Very difficult to comment. Either 160 or 180 could be the baseline, but it's very difficult to comment
Hmm.
as you're told.
Hmm. Hmm.
But yes,
Hmm.
definitely it is not acceleration. This is overshoot. You see,
Hmm.
this is the
Why
deceleration.
I
This is
thought that it could
overshoot.
be one. Yeah, yeah, yeah. You're right. Yeah. So why I
So
thought 160, because if I match the deceleration, so most of the decelerations, the upper part is
starting
going
at
to 160. Yeah.
Yeah, you're right. That is what I'm telling. It's difficult to comment upon, but yes, if you see this is a variable deceleration starting from here and this I take as overshoot, then I
Hmm.
will take 160 as my baseline. Here also this
Hmm.
deceleration started at 160. So you're perfectly right in saying that we can consider 160 as a baseline. We can consider
Hmm.
it as a drop and overshoot, right?
Hmm.
As a drop and
Hmm.
overshoot. If we
Hmm.
consider it here as a drop and overshoot. So
Hmm.
this is what we can take. But definitely there are two concerning features, so it become a pathological trace.
Hmm.
So in exam,
Hmm.
you don't have to tell everything. You only have to be able to understand that this is deceleration, not acceleration. Somebody might
Hmm.
say that it is 140 baseline and this is acceleration. You
Hmm.
get my point? If you are clear
Yeah.
in your concept, you can easily make out that this is variable deceleration. But Some might say that it is 140 baseline and acceleration.
Yeah.
Isn't it? So that's the difference.
Correct.
Once you understand things well, you can easily pick it up that it's abnormal. Okay, what
Yeah.
about this one? Thank you, Maya. Very nice.
Thank you so much.
Yes, who is planning to do this? Don't be afraid. Don't be afraid. Without exam, why to be afraid? And even in exam, why to be afraid? Whatever you know, you have to apply your knowledge. And here we are just discussing. We all know that we are weak at CTG, so we are discussing to enhance each other's knowledge. So it's nothing to be, afraid of. Anybody can attempt.
May I?
Yeah, go ahead. Who is this?
This is Mariam,
Yeah, go ahead,
MD.
Mariam.
Yeah, it is CTG for twin pregnancy.
Ah, very good. This is not a CTG for twin pregnancy. Actually, here in UK, they
Yeah.
have this maternal trace also. This is maternal trace. This is
Okay.
maternal heartbeat trace. This is not a
Oh,
twin pregnancy. Uh,
uh,
I wanted to tell it with the trace because otherwise you will not understand. This was something new for me also. When I came here, I saw that there is one tracing down. What is this? The milder one. So this is maternal heartbeat.
this is first time I have seen.
Even I have seen first time when I came here and understood that. And
Uh,
what is the benefit of taking the maternal traces? Sometimes if
we
the baby
compare.
heartbeat fall and it exactly look like maternal, that means you lost the baby and you are picking up maternal. So they get to know it very easily because they are monitoring the maternal pulse simultaneously.
Okay. So baseline is around 150 to
Okay.
150 to 145 is baseline, I think.
Okay.
Variability is good, and
Mm-hmm.
there is some decels along with the contractions. So it's most probably early decels.
Mm-hmm.
And there is 1, 2, 3, 4 contractions in 10 minutes. There is no
Mm-hmm.
tachycardia, no hyperstimulation. And
Mm-hmm.
it's a normal CTG.
Okay. So now if you see the
Mm,
contraction, you have to. It is the best ever session in CTG that I have attended. Thank you so much, Anam. So if you see the contraction, you told me 4 contraction in 10 minutes, if I'm not wrong, right?
yeah, 4.
So as I told you, in some CTG here in UK, it looks like same, exactly like this. So 12, 10, as I told you, this is the pressure, uterine pressure. So between
Mm,
two uterine pressure, either you calculate, or between two, this 100, either you calculate. So if you see the contractions maximum, it can go up till 3. Like if I count from here till here, I get 1, 2, 3. If I
mm,
count from here till here, I get 1, 2, 3, right? So it's 3
mm.
contraction in 10 minutes.
Okay.
Okay. And then the CTG is, I know this one is a difficult one. That's why I put this one. And this is from my hospital itself. That's why you can see the blood pressure is written and many things are written. The syntocinon started at 30 ml per hour, things like that. So
Mm,
uh, if you see here, the baseline you told correctly. And as I told you, baseline is not a very important thing. You should understand where the baseline is so that you can understand, is it acceleration or deceleration? You were right saying it is somewhere between 150 or something. If you see here, it is around 145 here. Then if you see here, it becomes 150. Then if you see here, again 150, then 150. Then if you see here, again, it is dropping to 140, the baseline. Again, here it is 130. So it's all right. It doesn't matter much as far as it is lying in between 160 to 110, right?
okay.
So baseline is all right. I'm not worried about baseline. Then the second thing I want to look is variability. You told variability is normal, which is perfectly all right. If you see here, 1 small box, 2 small box, so 10 beats, right?
5 to
So 10 beats somewhere, 5 beats somewhere, even 15 beats, 20 beats. This is one acceleration. So this is all good. CTG is good. Variability is good. Baseline is good. But I'm not convinced about early deceleration. Can you fit these deceleration into early?
Because they are started with contraction and recover along with contraction.
Okay, very good. Now you tell me, is all the deceleration, how many deceleration you can see in the picture?
Like with 1, 2, 3, and 4, 5,
Very good.
6.
6 even. 7 even. This is also a deceleration. 1, 2, 3 here, 4, 5, 6, 7, 8.
And all
Right?
with almost, yeah.
So do you think it all looks similar? It's all happening,
Variable.
starting with
Yes,
contraction,
variable.
ending with contraction. Do you feel like
Shapes
that?
are variable.
So what do you think? Is your
Wait,
early deceleration criteria fitting in?
no. Then variable T cells.
Yes. So this is what I'm telling. If you see now, once you want to
Mm.
fit in into variable deceleration, you will see that it is wider. There is shouldering. If you see here is also shouldering, here is also shouldering, here is also shouldering. So it's a variable deceleration, right? So as I told you, most of the time, we as an overseas candidate, we listen from our nurses that it's early deceleration because it is coming with contraction, but actually it doesn't fit into early deceleration criteria because variable can even come with contraction, right?
Exactly. Yeah.
Am I making sense? So try to fit every deceleration into variable deceleration until unless you can't fit into that, stick to
Okay.
variable. So first choice should be variable. And if you think that no, it is not fitting in variable, all are looking similar, all are coming with contraction, ending with contraction, all are having similar pattern, then it become early or then it become late accordingly.
Okay.
Okay.
Very good.
So this one thing, even I was not knowing before my exam. Believe me, I was really struggling with CTG question before my part 2 exam. But this
Which one?
all enlightenment came after I started teaching that, how CTG should be approached. Even I gave my exam with very weak CTG knowledge, but now I have much better knowledge than at that time. So at
Really,
least
we
you
are
can
taking
get benefited
advantage of
by that.
your knowledge. You are very.
Yeah, that is what. At least you can take benefit of that and make your life simple because I even get shivering when I see CTG at that time. But now no more because now
Okay.
anyways I don't have to give exam, one thing, the benefit. And the other thing is I know better now. So always, as I told you, 88% or more are variable. So
Okay.
try to fit into that until unless you are not able to.
Okay. Thank you. Thank you very much.
My pleasure. Okay, now this one. Who wants to attempt this? Yes, Parajakta, Dr. Safa, Dr. Kha. Many names are there, but nobody wants to speak. I love different voices. Dr. Kin, Dr. Rabia, Dr. Karmeen, Dr. Poonam, Sirisha, Dr. Asma, Ghazala, Anam, Rehana, Safia. Many people are there, but nobody wants to open their mic. My dear Rehana, your mic is constantly seen to me as open. Let me check. No, you're not mute by me. I'm so sorry if it is showing like that, but I have not muted anybody, believe me. Yes, anybody, please let us not waste much of time because everybody's time is precious on Saturday. So whoever wants to read, please go ahead.
Ma'am, I'm
Go
going to
ahead.
tell about that.
Yeah, go ahead.
There are four contractions in 10 minutes,
Mm-hmm.
and the baseline heart rate is 140 beats per minute,
Mm-hmm.
and the variability is more than 5,
Hmm.
and I can see the early decelerations.
Okay, why do you think it is early?
It is coinciding with the contractions,
Hmm.
But in the scenario, there is a history of cord prolapse.
Unfortunately, I forgot to crop this up, but ignore that. This part you ignore. There's no cord prolapse. You tell me about the CTG. We are here not discussing scenario yet, only CTG knowledge we are testing. So do you think it is early deceleration?
And it seems like early deceleration.
Yeah, I totally agree with you. My nurse will totally agree with you. Even 2 years back, I would agree with you, but now no more.
Ma'am, this is late deceleration. Even I will say that there is a mixing of early as well as late.
Early and late.
So is there anything like early and late?
No, so this will be called as late actually, mostly.
Variable deceleration.
This is late
Va-
Very
deceleration.
good.
Deep
Very
variable.
good.
variable
If it
decelerations.
if it looks to you like early and late, it automatically become a variable.
Variable.
Variable, yeah. Yeah.
Again and again and again and again, I'll keep telling you, try to make every deceleration variable until unless you don't fit into that.
But the ma'am, the decelerations are all similar, ma'am. They are not variable. As you told,
Yes, it's not
the
exactly
deceleration.
similar. If you want to, if we'll play that 5-5 difference that we used to play in childhood, right? Find 5 difference, find 10 difference. You will find many difference. The shape, if you see this
Okay.
is wider, this is narrower, this is comparatively wider, right?
Yes, ma'am.
This
Yes.
is so it is all you have to have the eye to look for it. That's why I'm telling you, try to fit everybody to variable until unless you can't fit into that. If you see this is overshooting sort of pattern.
Okay. Oh, yes, ma'am.
If it is a
Overshooting.
late deceleration so deep, will the women variability will be normal?
No.
It's an acute drop. It's an acute drop, first of all. It's not a gradual drop. It's an acute drop. Do
Yes.
you agree with me
Yes, ma'am.
now?
Yes,
Means
yes, ma'am.
you see how I changed your mind? Well,
Less than 30
I
seconds.
know it's difficult. You know, I know it is difficult, and I really believe me, I totally agree with you all, and even I face the same thing. But now, once you know more and you apply and try to fix yourself like that, it's easier to fix into that. If you want to make it a late deceleration of a 60 beats, it's quite detrimental, believe me. You will not get any variability.
Yes,
As I
yes, ma'am.
told you, variable
Hmm.
deceleration late deceleration always come with decreased variability.
Yes.
So, and at the baseline, the variability is looking all right. But
Yes.
here, no variability. It's different in size and shape according to me. There is overshoot, there is acute drop.
Yes, ma'am.
So all
Yes.
this
Okay.
is not fitting into late. So it's a variable deceleration for
Variable
sure.
distillation. Okay.
That's why I told you, always we get confused. First of all, you told me early, right? So
Yes,
always
ma'am.
we get confused because we get biased by seeing the synchrony with contraction and we don't note the finer detail. So if you see the drop exactly is falling after the contraction, we may say, or if you see the peak and the peak and the nadir, it's not corresponding exactly. It's not like a image of a contraction. It's not a V-shaped sort of thing like gradual fall, gradual rise. And early will not go so deep, believe my friend. Early will not go to 60 for sure. Early
Okay, ma'am.
decelerations are very small ones, very cute ones, which will never be so deep and, naughty, where you cannot, it means it's really bad. This trace is bad variable deceleration, according to me. Am I clear? Am I making sense? So it's a
Got it,
variable
ma'am.
deceleration. By looking the
Hmm.
trace now and by looking the history also, you know that it is a variable one. But believe me, this is how I made the mistake. This is how I learned in my also course that sometimes I'm mistaking other deceleration as early. That's why my babies are not coming all right. So if it is early, I'll leave the baby and the baby will die because this is cord prolapse variable deceleration because of cord compression. And with concerning feature, I should act within 30 minutes. If I don't act, baby will die. This is 20-minute trace given to me, but still I will label it as pathological because it is with concerning feature, with all the contraction. So here, sometimes even in my exam, the trace was not 30 minutes, but still I can make out, now I can make out that it's a pathological trace and I'm going to act upon it. So if it is fully dilated, I will do instrumental delivery for a cord prolapse. If it is not fully dilated, I will do cesarean for cord prolapse, category 1, because it is fetal heart abnormality. If with cord prolapse, the heart abnormality is not there, it becomes category 2 cesarean. So that's anyways a different story. We will cover that in cord prolapse. Okay, now this one. This is from Saudi Arabia, fresh. Yes. This is different machine. So if you see here, there is no line but dots. But again, this is a big box, and this is 5 beats, 10 beats, 15 beats, 20 beats. So 20 beat difference, all same. Only in place of line, there is dot. Yes, anybody can take it. And believe me, here we are discussing, not judging anyone, because we all are weak in CTG, which we don't know. So we are trying to upgrade each other's knowledge. Yes, come on, anyone can open. You see, even in one session, I already taught you CTG, and I'm trying to stimulate you people to open your mic and read it. And not even half, out of
Can
25 students, nobody's opening up. How much
can I
motivation you need to prepare for exam? No, I'm just trying to give you an example that how much motivation you need in this exam. It's a long time thing. You need at least 6 month preparation. That do you think that you can stimulate yourself every day? It's a difficult job. So group study is always recommended for this exam. That's why to stimulate, poke each other to read.
the
Yeah,
baseline is
go ahead,
okay.
my dear. Yeah, go ahead.
The baseline is okay. The variability is also okay,
No,
ma'am.
what is okay? What is the baseline?
Sorry. The baseline heart rate is around 130 beats per minute.
Okay,
That is normal, within normal range, and the variability is also between 5 to 20, 5 to 10, and somewhere 15, 20 also. That is also
very good.
fine. Then there are accelerations.
Very
The
good.
number of contractions 1, 2, 3, 4, 5, around 4 to 5 contraction per 10 minutes.
Okay, very good.
Mm,
And
I can
any
see only
decelerations?
accelerations.
Okay.
Deceleration.
Okay, very good. Perfectly
This
all
one.
right. So what kind of CTG is this?
This is a normal CTG, I guess.
Very good. No, not guess. You should be confident by now
Yes, yeah.
because you can't see anything abnormal in this and see such a
That's
big
right.
acceleration. So you're
Hmm.
very happy. If you see the baseline here, it is 130. Here it is 140,
Yes, ma'am.
somewhere in 140. So to start with, it was 140. Gradually, it came down to 130, and then it went here up till
Yes, ma'am.
150 maybe. But anyways, it doesn't matter. It is in the normal range. Good variability. If you see variability, if you see here, it is somewhere 5 beats here. If you see 1, 2 boxes, 10 beats, I mean small boxes. Here almost 10 to 15 beats. Here again 10 to 15 beats. So good variability, good accelerations, no decelerations. Very good. If you see the contraction between these to this number 1, 2, 3, 4, 4 contraction, 1, 2, 3, 4, 4 to 5 maybe. This is small if I consider contraction. So good. So this is a normal accelerative trace. I'm very happy. Don't think that the variability is less because variability will not always be constant. It will keep decreasing, increasing. As far as it is variable, the variability is variable, you are happy. If it is consistently low, then only you will tell that it is less than 5. Because here it is looking less than 5 in this stretch, but here it is more, right? So you will label it as normal variability. If this will persistently be there for more than 50 minutes, then I'm worried. So that's what you have to understand. Very good, my dear. Okay, now this one. Again, this is maternal trace, maternal heartbeat. this fetal trace, and this is the contraction. Who wants to describe this? This should become easier now for you. Yes, anyone? No need of describing full CTG. It is very regular, but as I told you, if you get the picture like this, count from the base 60, 80, 100, 120, 140, 160. So here is the trace. Just tell me, is it a normal, suspicious, or pathological CTG? Anybody can tell me.
This is normal CTG.
Normal CTG.
Yes, any more votes?
Early
Suspicious.
deceleration.
It is a pathological CTG.
Very good. Any more votes?
This is suspicious CTG.
What kind of deceleration you are seeing? Yes, let us go to that.
Very
Some told it is
Variable,
normal, some
variable
told suspicious,
deceleration.
pathological.
It's
Shouldering
variable
time
decelerations more
Variable
than
deceleration.
50% with
less than 60
concerned
beats drop
features.
with
Variable
shouldering time.
deceleration with variable
Shouldering
deceleration.
less than 60 beats drop,
Hmm.
but more than 50% contractions.
And is there concerning features or not?
If more than
Yes,
50%,
There are
yes,
concerning
W
W is there and no
W is
shouldering sometimes.
Very good. So CTG is pathological
okay.
because of one is variable deceleration with concerning feature, and what is the other wrong feature in this?
Low variability.
Very good. So it is a pathological trace. The reason low variability. See, whenever you will see such a frequent deep means some decelerations are really deep. If you take the baseline somewhere around 140, maybe yes 140 if we take, see how deep it is going. Means it's going more than 2 boxes, means more than 40 beats sometime. And getting with every contractions means it's a variable. So as I told you, variable can be with contraction anytime, anywhere. It's different in size and shape. It's happening so frequently. So definitely the baby is compromised. That's why the variability is less. So it become a pathological CTG. Some of you told it is a normal CTG also. So again and again and again, I'm telling you, all the decelerations are variable decelerations until unless proved otherwise. Like we tell, any pregnant women getting fit is eclampsia until unless proved otherwise. So please open your eyes and see. You cannot see it as a normal CTG, because if you see it as a normal CTG, okay, tell me, where is the baseline? You will see this is the baseline. Where is the acceleration? Where is the variability? All are deceleration. So how can it be a normal CTG? The deceleration are not early, so how can it be a normal CTG? Some of you told it normal because you thought it is early deceleration. Again, early deceleration is only 5%. It's not similar looking. Different size and shapes, different depth, acute drop. So in spite of knowing all the fact, when we see CTG, until unless we are daily seeing CTG in our workplace, it's difficult for us, right? So please try to look for variable deceleration in every CTG is what, again, my recommendation. Okay, this one. Now this is a scenario, a primary gravida, no risk factor, 40 weeks, under epidural, vaginal examination 9 centimeter dilated, comment on the CTG and management. This is also from Saudi Arabia, picture taken by me, PC me. Okay, so who wants to describe this?
There is a prolonged deceleration.
No, let us take it now like Dr. C. Bravado. So determine the risk. What is the risk?
Epidural.
Epidural is actually not a risk, but yes,
No,
a
but
transient risk
hypotension.
can we give. But determine the risk means what is the maternal history risk, not the epidural thing. That's when
But
the obstetric anesthetist give the epidural, they keep an eye on them. That's a different thing. That's not a determined risk. Determined risk means mother has any history, baby has anything, meconium, IUGR, hypertension, diabetes. That's the determined risk. So here there is no risk because the women has no risk factor. Okay, contractions.
are 3 to 4,
Okay. Then
irregular 3 and 10. Baseline is normal. Baseline variability is normal.
no, what is the baseline?
Baseline is started from 130 and then going
This
to sometime
this is
110.
this is 120. So is it reaching any time? You mean here it is going
Here
to,
it is reaching down. No?
pardon?
Here is a deep deceleration without any
No, no, no,
contraction.
no, 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 no. We are still on baseline. What is the baseline?
Baseline is 130 or 110.
130 is here.
110,
This is
110
130.
is 120, 110.
Yes, 120, and then in between it is going down to 115,
110,
and
and
here
within
it is
100,
again
less than 100.
120.
Yeah. Again, it is improved.
Less than 100 is not baseline. The baseline is maintaining somewhere at this range. Here it
Yeah.
is not so clear. Again, you mean here it is, that
Yeah.
is a deceleration, so you cannot take it as a
Prolonged.
baseline. And this is the baseline here and here. Okay, very good. Now, what is the variability?
Variability is normal.
Yes, very good. What else?
Very normal.
Acceleration, any acceleration you can see?
Yeah, there is accelerations. Initially it was no acceleration, but at the end there is,
This one you mean?
yeah, this one and before this one, 10 minutes.
This one.
After improving this diesel, there is some accelerations.
Okay, and what about deceleration?
This in next means in 30 initial after 2 boxes there is deep diesel.
This one is a deep
Loss of
deceleration.
contact or,
Could be loss of contact. Very good. What else?
but the baseline is less here, 100 in
Because
this
it
box.
is recovering. If we tell it that it is recovering from deceleration,
Yeah,
so
from 100
definitely the
again
baby
it
will
was,
take little time to recover. So
yeah,
if you
maybe
take, maybe if you lost the baby here, loss of contact, so gradually you are picking up the baby, so then the baby is fine here, right?
yeah.
The good variability.
Might be it is because of hypotension and then after some resuscitation.
She is under epidural. Maybe she has received earlier. Nobody means the thing is, if I give epidural here, yes. If I give epidural here, I may say that it is because of epidural. But if she's already under epidural, it's only in the beginning, not after that. Means after that you give them fluid and monitor the output. So usually if they give you a trace of bad CTG after epidural, it will be immediately after epidural they will give you.
Okay.
But yes, if I give epidural here, yes, it could be because of epidural as well, due to hypotension as well. Okay, so what you are going to do, what category you keep the CTG then?
Means in the last minutes it is normal.
Yes, so what category
it is normal.
You have to tell the CTG for last 30 minutes. Whenever you review a CTG, you have to review for last 30 minutes.
Last 20
Sometimes
minutes it is
20
reassuring.
minutes it is normal, and then this is less. So what category you will keep the CTG to? Is it normal, suspicious, pathological?
Suspicious, because we need 10 minutes more to reach the conclusion.
Yes, so it comes under the suspicious CTG. Why? Now, this is what everybody is seeing. What about any other deceleration you can see?
No.
What about
Initially,
this one?
yeah,
What
initially there
about
is.
this one?
Yes, there is initial deceleration. Yes.
Late diesel.
Even with this contraction, there is a small drop, but this is mostly variability change. Anyway, so I'm telling that if you have eyes to look for it, you will always find some variable deceleration here and there. So I will
Yeah,
label it
that
as
too.
variable deceleration because as you, again, different in size, shape and things. And this could be either a loss of contact or it might be a deceleration which recovered well. So I'll keep it under suspicious and I will monitor the baby.
Okay.
Very good, my dear. Yes, this one. Who wants to do this one? CTG of a low-risk primary, 39 weeks, started epidural at 15-20 hour due to severe pain. V was 9 centimeter dilated, 100% effaced. Describe this under the heading of Dr. C. Bravado. Yes, anyone? It's a fun activity, isn't it? To read the numbers. If you see, this is 1 centimeter per minute CTG trace. Vaginal exam here. She was 9 centimeter. Yes, come on, please. If nobody is interested, then
There is no risk, and there is no risk. It is mentioned low risk.
yeah,
Then
very good.
the baseline heart rate is around 140.
Yes.
Then after then the contractions 1, 2, 3, 4, 5. Initially 5, 5 to
Hmm.
4, yeah, 5 to 6 contractions in 10 minutes.
Hmm.
And then there was a maybe because of hypertension after starting epidural, there is a prolonged deceleration after
Very
15,
good.
21. Yes.
Very good.
And there were accelerations initially.
Very good.
Yes. No more decelerations are present, only the one which is related to maybe hypertension.
Yes. Very good. So if it is clear in your mind, if you go by method, what you're following, if you see very good acceleration here, very good acceleration here, and this might be related to epidural. That's why I put this one, because sometimes after epidural, you see prolonged bradycardia. You're not going to act upon that. Most likely hypertension, replace the fluid, give her left lateral and watch. So keep your eye for that. In question, they have mentioned epidural given just now like that. If they give you, they will definitely give you a CTG with bradycardia with epidural. So be careful about that. Otherwise, the CTG is beautiful, baby is doing good. There is acceleration, variability, everything is good. Contraction, if you see here to here, not 6, maybe I will say if this one, definitely not a contraction. So 1, 2, 3, 4. Even if I include this and this, 5, but then this is in the middle. If I see between this and this, it will be 1, 2, 3, 4, 5. So I will say 5 rather than 6. So contraction, why it is important, the 5 criteria, because if it is more than 5, then I have to keep an eye.
Yes, ma'am.
If it is
Yes,
more than
ma'am.
5 with abnormal CTG, I have to give to cholecyst. So be very careful when you're
Yes, ma'am.
labeling it more than 5. And whenever they will give you more than 5, they will definitely give you scenario accordingly. So it's a good CTG, and this is because of epidural. Okay. Anyone? A gravida 5 para 4 in active labor at 8 centimeter. What do you think? What kind of deceleration? Let us not describe the CTG. Tell me what kind of deceleration she is getting. That's it. These are the real CTGs. This is not for teaching purpose. So this is not fabricated. What kind of deceleration she is getting? Again.
Variable.
Early, early.
No, they are variable, definitely.
Yes. I also might label it as early, but then again, it is different in size and shape, so it is not fitting into early.
Variable distillation.
So that's what I'm telling. This, when I put this to my study group, when we were doing CTG questions, we used to do it. I used to send them from labor ward whenever I'm on labor ward duty to the students. I sent it to the students thinking that it is early, but then students told me, Madam, it is variable. So, sometimes everybody can get confused that it looks like early, but actually it is variable. Then I realized, yes, you're right. The shapes are different. The size is different. So it's variable deceleration. So if it is variable deceleration for more than 90 minutes, I'm going to be worried, even if it is no concerning features, though if you see it is with concerning feature here, right? Here there is shouldering. Here again, it is not there. So it's with concerning feature. If it is with concerning feature, 30 minutes is enough to label it pathological. So be careful in exam because early and variable sometimes become very intermixed and we get confused, but it's variable. Okay, so that's all very good. So you all got the groove that most of the decelerations are variable. This is how the question they put in the exam sometime, that categorize the CTG. So this we are not going to read this. I just put for you to show how they make the EMQ sometimes by simply testing your knowledge of how much you are remembering how to categorize a CTG. Okay, let's read this. Who wants to read this?
May I?
Yeah, go ahead.
30 years old, 835 weeks of gestation, is admitted in spontaneous labor. She is fully dilated. On examination, the head is 0/5 palpable per abdomen in left occipital anterior position with minimal caput and no molding. She has made good progress from 3 centimeter to full dilatation in 3 hours. She has been pushing for 1 hour. You are asked to assess the CTG.
Okay,
So
you have to follow this.
determine risk.
30
year 35 weeks, so she's preterm.
Very good.
And contractions, 1 2 3 3, she has 3 contractions, and baseline rate is, I have to make it bigger because it's very difficult to see the numbers.
You know, this is the CTG they give you in exam. Now, how you will do, as I told you, 60, 80, 100, 120, 140, 160. Here is the 160, 180, 200. You know that the numbering start from 60. So go
60,
by
okay.
your gut line.
60, 80, 100, 120, 140, 160. It's between 160 to 165 or 70.
Whatever. So it is in the suspicious range, means non-reassuring feature, the baseline even. Okay, good.
And
Then,
acceleration, there is no acceleration.
okay.
And
We are following this contraction baseline. Okay, variability.
Variability is normal.
Very good.
And cells are variable in shape because somewhere it is biphasic.
Very
and
nice.
Means long recovery time in some. And there is absent of shouldering sign.
Very good.
And overall impression is like baseline heart rate is increased, and number 2 is variable decel with concerning signs, and more than 50% of the contraction in 10 minutes. So it is a pathological because it
Very
has
good.
two
Because two
abnormal.
non-reassuring. Very good. So what you're going to do?
So now she's as a primary. She's 35 weeks, 0/5 palpable per abdomen, left occipital anterior position, minor caput, 3 centimeter only means early labor. So I should go for
No. She
No,
has
fully
become
dilated.
full
She's
dilatation and pushing for 1 hour.
instrumental
Good
delivery,
progress.
ma'am.
expedite the delivery by
Okay.
doing some instrumental delivery, like
Very
a
good.
forceps, because she's preterm. No?
Yes, ma'am.
So
Preterm.
Very nice. Beautiful. Wonderful. Very good. So once you know the risk factor now, because you understood it is preterm, you cannot do vacuum. So if they will give you here kiwi and forceps, you can choose forceps for sure.
forceps.
Because here they have not given you anything. You are considering instrumental delivery because it is 0/5 palpable. It is perfectly all right to do instrumental delivery. Sometimes they'll give you 2/5 palpable here. If they give
Then
you that, then you will choose directly emergency cesarean.
yeah,
Anybody who is fully, you will always try to consider instrumental delivery if possible, if it is fitting into the criteria. If not fitting into the criteria, bad CTG fully and more than 1/5 palpable, like 2/5 or something, you will straight away go for Cat 1
cesarean.
CS. So very good,
Dr.
Maria.
Shweta, but
Wonderfully.
this
Yeah.
This patient actually should be going for trial of forceps, isn't it? Because she is LOA with 0/5 and
Basically, they
No,
have not mentioned the station from down how much it is, but yes, it could be trial, but it doesn't matter. Means here, every question is made to test something. It's not like every time they are testing your knowledge of will you deliver in theater or will you deliver in delivery room. Whenever they make a question, they make a question with testing some part of your knowledge. So here they want to test your knowledge that for a fully dilated woman, 0/5 palpable, will you do cesarean or will you do instrumental delivery? If they want to test your knowledge to do in theater or to do in room, they will give you station +1, +2, whatsoever down, and they will here give you more confusing option like kiwi, forcep, in room, in theater. So they are not testing that here. You get my point, what I'm trying to tell you, because labor questions, in one scenario, there could be 100 things, but they will not test all the knowledge all the time.
I mean, honestly speaking, I'm still very confused still about the CTG because I felt that there are three decelerations which are having like sustained and they are like more than almost 2 minutes.
Yes, you're right. So that is why it is concerning character. That's why
So
you're
why
delivering.
So, but when we are not sure about the head, like if I go with the scenario, and if I'm not sure about the station they have not given me, then I do not know
They
where
have
is
given
the
you
baby head.
0/5 palpable. If they have not given you +1 or whatever from vaginal, per abdomen criteria is fitting into instrumental delivery.
But 0/5 palpable, Dr. Shita, can be with anyone, na? I mean, it can be with 0, it can be with +1, it can be with +2.
Yes, but even for 0, even for +1, you can apply the instrument. So it is not like instrument is contraindicated. If anything, up till 1/5 palpable, you can apply the instrument. So they have given you 0/5. So there is no contraindication for instrumental delivery here. You have to understand the knowledge given here. Don't ask for more thing. Whatever they have given here, you have to apply that knowledge and get an answer. So what other answer you think you want to choose then?
No, that's fine. I mean, I was only considering that only. That's it. Nothing specific.
So you want to apply instrument in theater. It's fine. They have not mentioned specification. They told consider instrument. So yes, we are doing that. You apply either in room according to the station, you apply in theater, it doesn't matter. But here they're not testing that is what I'm telling. That's why they have not given you the station from below. If they want to test that part of your knowledge, they will definitely give the station from below and they will give you, as I told you, more confusing option of instruments and where to do it. But here they are trying to test, will you do CS for this lady or will you do instrument? So per abdomen, she is fitting well into the criteria of instrument. So this much knowledge for me is enough to apply instrument for her because its per abdomen examination is fitting into my criteria. You get my point?
Yeah, I agree. Yeah.
It's a pathological CTG in a fully dilated women, preterm, and 0/5 palpable, which is fitting in instrumental delivery. So I'll apply it. For example,
Yeah.
means not in my practical experience.
Dr.
But
Shweta, can you explain to me one line which I don't understand, or maybe I'm not very clear on that, that when it is occupying more than 50% of the contraction, so in this particular CTG, how will we calculate easily that particular thing?
more than 50% of contraction, very simple. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 contraction. How many deceleration? 1, 2, 3, 4, 5, 6, 7. So 9 contraction, 7 deceleration. Or even if I
But
take 9 and I take it as 1, then it will become 9 contraction and 6 deceleration.
but couple of time it might happen that the contractions are not very clear and it is just coming like it's like you can't understand, it is incoordinated type of trace in the contractions.
It's all right. In that situation, you have to count. If you want to count more than 50% or not, the simple thing is count as many contraction, count as many deceleration. So here it's very clear. 1, 2, 3, 4, 5, 6, 7, 8, 9. 1, 2, 3, 4, 5, 6 either. Or if I consider it 2, then it becomes 7. Both ways, it is more than 50%.
Hmm.
Am I making
Okay.
sense?
And if you can you show me the previous CTGs what we discussed, if we can go once about that as well. The previous CTGs what you have shown in that if there is
Like
some
here.
specific.
Here to here, how many
No,
contractions?
not this one. No,
Total.
where there are contractions are not defined, I'm saying. Like in this contractions are defined.
Here, maybe? Yeah, is it not defined? For me,
No.
most of the time contraction are defined, so it's difficult for me to find one. Here it is clearly defined. Here it is clearly
Yeah,
defined.
let's consider this particular
One,
one. So in the center
this,
part, not this one, the previous one, before this. Yeah.
this one,
No. Yeah, this one.
this one.
So in
Yeah.
this now, not this one.
So you're
Oh, it will
finding
not.
all the
Yeah, this
contraction
one.
defined now. I'm
No,
sorry.
no,
But the
no,
thing
no.
is, the thing is, I can understand what you're trying to ask. Like this one, I'll say the contraction are not very clear in this CTG. If you say
Mm,
one here,
mm,
if you see here, 1, 2, 3, but you have to understand that when they want to calculate that, the variable deceleration with like this one, the variable deceleration with number of contraction, they will give you a CTG which has clear-cut demonstration of contraction. Like here, the contractions are not very defined, but it doesn't matter because I'm not having a deceleration. So when they want you to count, they will give you a clear CTG. You get my point?
mm.
You do have a CTG where the contraction are not very defined like this one, but then
So
they don't want you to count even.
okay, if in case we consider this CTG, but let's say take that the trace which is up, or all the accelerations which we can see, let's make them as decelerations.
The thing is, they will not give you an exam like this confusing scenario. In practical
Okay.
point of view, in your labor ward, you will see this. But in exam,
Hmm.
they are not so cruel, They वो तो कहते हैं ना कि वो monster also have some rules to follow. It's like that. They're not so cruel that they'll confuse you in every aspect. If they want you to count the contraction, they'll give you a CTG where you can count easily. So don't worry.
Hmm.
They
Okay.
are simple people. If you know the rules, it's easy. They are not going to confuse you till core, believe me. If you know your rules, if you're clear in your basics, you can clearly pass this exam. I know we sometimes make our life more difficult thinking more, doing more critical thinking. So think
Yeah.
simple, stick to your rules. It's easy to clear the exam.
Hmm.
Because we develop the habit of critically thinking everything and making our life more. And here also, if this is my exam question, it's very simple. Clearly, they have given how many contractions and how many. It's a made up one actually, because it
Hmm.
doesn't come with the
Yeah.
orange and blue color. So it's clear for you to, count it. Okay, very good. Next, who wants to read this? Yes, go ahead. Anyone? Don't be
Can I
afraid.
read?
Again, I told, don't be afraid. Go ahead.
Can I read it?
Yeah, go ahead.
So 27-year-old Loris Primigravida at 38 weeks of gestation has rupture of membranes at 5 centimeter with thick meconium and uterine contractions at the rate of 3 in 10 minutes. She is commenced on continuous fetal heart monitoring and a plan is made for re-examination in 4 hours when she is found to be 6 centimeter dilated and has normal CTG. Syntocinon is commenced following medical review. She is re-examined by the registrar 4 hours after onset of contractions at the rate of 4 in 10 minutes and she is found to be 6 centimeter with 2 plus capute and the CTG is non-reassuring. What is the next most appropriate next step? Is it a CAT 1, CAT 2, FBS, increase syntocinon infusion, reassess in 4 hours? Okay. So the risk factors here are thick meconium.
Mm-hmm.
She was in early, first stage of labor.
Mm-hmm.
Contractions were initially less, but then later on they have said that it was 4 in 10 after the syntocinon, so that is okay.
Mm-hmm.
And initially when it was 5 centimeter, sorry, and then she became 6. So that was a suspected delay. After that, syntocinon was commenced. So then it was 6 centimeter again. So that means this was a prolonged first stage, clearly. And prolonged first stage with 2+ of capute. So she is not progressing. So this is a confirmed delay now. And CTG is also non-reassuring. So it should be Cat 1 if it is non-reassuring.
Cat 2.
For pathological CTG, it is Cat 1. For
Yeah, so
non-reassuring, it will
this is
not be Cat 1.
non-reassuring. Yeah, sorry, I'm mistaken. Yeah, it is CTG is non-reassuring, not pathological. Yeah, so it will be Cat 2.
And why you're not considering blood sampling here?
Blood sample. Because she's already having 2+ capute and she's in prolonged first stage. I will consider blood sample if I think that patient, I mean, I have some time to give her and I can understand that there is a reason by which she can still deliver vaginally.
So the reason for you delivering her is non-reassuring CTG?
Thick
No,
meconium.
it is a thick meconium baby and she still has a long way to go. She's only 6 centimeters since
So
last 4 hours.
that is
So
what
there is
I'm
some
asking.
other
The
reason.
reason for you doing cesarean for her is it slow progress? Is it non-reassuring CTG?
It's a slow progress, and I'm suspecting it's the problem of the passage, not of the baby or anything. So maybe
That's
there
all
is a
right.
pelvis.
In your practical purposes, in your labor ward, you will section her. That's fine. I'm just trying
Mm,
to justify it from NICE intrapartum guideline. Why
mm.
you are taking her for cesarean according to the NICE intrapartum guideline? You tell me that. For non-reassuring, I don't have to act. I am not going to section her for
Because
non-reassuring
it has
CTG.
got a thick meconium also, no? So there is a concerning feature.
So thick meconium, that's why I'm monitoring her with continuous CTG, and CTG is non-reassuring. So I'm not going to section her. So why I'm
Confirm
sectioning
delay.
her? Confirmed delay. So
Confirmed delay
delay
for
is
prolonged first stage.
confirmed delay. So for all confirmed delay, do you section them?
Along with
Yes.
2+ caput.
Yes, 2+ caput. So what?
Baby in distress because of
Confirmed
meconium.
delay. So why don't you augment the labor?
Already she's been augmented.
So she's already
Two
having 4 in
complexes,
10.
ma'am.
She's already achieved the target, no?
Very good. So the thing is, you cannot augment her further. And there is clear-cut written in NICE intrapartum guideline that if after starting syntocinon, adequate contraction for 4 hours and no change in PV examination, you have to section her. So you have already given her 4 hours of good contraction and no change in vaginal examination. So the reason is not diagnosed delay. The reason is 4 hours of syntocinon leading to regular contraction with no change in vaginal examination. Do you get my point now?
Mm.
If here they would have given me
Yes.
2 hours of syntocinon, I would choose increase syntocinon infusion and make it 5 in 10. They have given me 4 hours of synto, regular contraction, no change in cervix. So I am choosing cesarean. Do you get my point now?
Yeah.
Because the rule is with syntocinon, after 4 hours, if no change in cervix with good contraction, you have to suspect CPD and do cesarean. Do you get am I making more sense now?
Yeah, definitely.
So it's not because of diagnosed delay, it's because of the syntocinon rule of 4 hours. Syntocinon commenced, re-examined 4 hours after onset of contraction and still no change in cervix. So 4 hours of regular contraction, no change in cervix, then it is cesarean. Everybody's clear now that this is what written in NICE intrapartum?
Ma'am, category 1 or 2?
1 if pathological, 2 if non-reassuring. So because it is non-reassuring, so 2.
Okay, ma'am.
Okay, so this is what, and definitely the thick meconium, yes, CTG is non-reassuring. That all are our practical things. But you have to fit in the intrapartum rule according to which if 4 hours of synto and no change in cervix, you have to do cesarean, no further weightage. So this is what you will do. Okay. This is the last one, I think. Yeah. Oops. Yes. Go ahead. Who wants to read this? So in labor ward questions, the labor ward module questions, it is so long that by the time you reach the end, sometimes you forget the beginning. So always keep a habit of reading it very carefully. They give you time like 1:20 and then 2 o'clock. So how much hours, how much difference in vaginal examination, all that you have to read very carefully. Okay, go ahead. Who wants to read this?
May I?
Yeah, go ahead.
A primary class woman, 8:33 plus 4 weeks of gestation, is admitted in labor at 11:30 and was found to be 3 centimeter dilated with fetal head at -2 station. She ruptured membrane and draining clear liquor at 13:20. You were called to review the CTG 8:14. Baseline 150, variability 3, no acceleration, and variable decel more than 60 beats and lasting more than 60 seconds for last 35 minutes, occurring with almost every contraction. On vaginal examination, she was 5 centimeter dilated and blood stain lacquer was noted. What is the next most appropriate course of action? Expedite delivery by category 1 Caesarean section.
Very good.
Will be
So
the
why
answer.
you are not? So what is your CTG here?
CTG is pathological. Along with that, there is a blood stain lacquer.
Very good.
And
So pathological
the
CTG with
abruption,
bloodstain liquor. So you are not going to do fetal blood sampling. You will directly deliver her by a cesarean section.
abruption.
If the bloodstain liquor would have not been given, I might choose fetal blood
Yeah,
sampling.
then, okay.
Okay.
Yeah.
So just be clear about that fact. Very good, my dear.
Thank you.
So this is how you have to go about CTG scenario. This is how you have to read the CTGs and make your plans. It's not difficult if we stick to the rule, believe me. Any questions anybody is having about CTG now?
Dr. Shita, are you taking the other anything specific also for the exam point of view?
Are you giving January exam?
Yeah.
I'm sorry. It's only 10 days left for the, I think less than 10 days left for the exam. This is my last session for January because there's no more time.
Oh,
I have a
really?
lot of
I joined it
commitment
for the
here.
first time. Okay. No, I joined for the first time actually, but I liked it. It was really nice. Thank you.
Jan 17, your exam, isn't it?
Yeah.
So I think there's not enough time now to listen to anybody. I think you should focus and revise your notes and all the best,
Yeah.
all the best
Thank
for
you.
your exam. You will do good, don't worry. Just be
Thank you
confident
so
and
much.
calm in exam is what my advice to all exam going candidates.
Thank you so much. Thank you. But it
My
was very
pleasure.
informative. Thank you. It was nice.
Thank you so much. Thank you. Okay, so anybody wants to join us for July, they are more than welcome. And as I told you, for next 24 hours, you can avail for the 40% discount. This is our face group, Telegram, YouTube links. Any query, you can message me on this number, mail us on this mail ID. Thank you so much for attending today. I hope you all learned CTG well. Thank you, Karveen. It was very fruity session. Thank you. Good adjective. Okay, all the best for all Jan candidate and all July candidate. Please pull up your shocks and start preparing from now itself. It's very, very important that you start now.